Similar items for infra-inguinal CTO. It significantly reduces the need for major amputations or bypass surgery. Take home message, it is a key tool in endovascular armamentarium for limb therapy. Thank you.
Thank you very much. Perhaps I can start with a question. Thanks for your presentation. So, in your clinical application, you said it significantly reduces the number of amputations. Can I ask you to expand a little bit on that, on why you mention, or why you say that it reduces the rate of amputations?
Because the retrograde tibiopedal axis is seen in CTO patients, mostly non-reconstructible disease or failure to cross lesions. This might lead for acute amputation or amputation-free survival later on would be compromised. But ability to cross and successfully treat might prevent this amputation and provide patients with amputation-free survival.
और ये प्राइवेट को पब्लिक कर दो पहले हाँ
I might ask a question if that's okay. This was published, this is a series that was collected over 3 years up until 2019. So there's been 6 years publication delay. Do you have any comments on that? And also, was there any mention of a contemporary cohort of surgical revascularization strategies, open femoroplasty or femorodistal bypass, given the recent findings of the Vsi trial?
They have not mentioned about open revascularization procedures, sir, but they have quoted 2 studies by Smith and Welling. Yeah.
Yes.
And the delay in the publication, do you think there's any significance for that 6-year delay?
Right click करके ना
I'm not sure, sir.
Okay. इसका लिंक हेलो इसका लिंक शेयर करना है तो लिंक आप
on the type of lesions. So you mentioned about the length of the lesion, but the type of lesion that was impossible, were they mostly SFA lesions, popliteal, or
thank you very much
for this cohort?
Most of the patients, I don't remember the exact numbers here, but at least 30 to 35 patients were infrapopliteal. They have mentioned about the degree of calcification, severity of calcification, and class staging. But specifically SFA or popliteal lesions, they have not mentioned the detail.
Project?
18 patients, they were not able to cross the lesion. So in that 11 patients, they were able to revascularize via open. 7 patients had to undergo amputation. Thank you.
Thank you, Dr. Susan. Next, we'll have Dr. Lili Devi Krishna Shashidhar.
Open it.
Good afternoon. I'll be talking about the journal titled Outcomes of Supera stent used for treatment of de novo or restenotic esophageal complex femoral population lesions. It is a prospective multi-center non-interventional registry which is conducted across 20 centers in India. A total of 284 patients were recruited. Few patients were lost on follow-up or expired before the completion of study. So 262 patients completed a 12-month follow-up. The patients of age group between 18 to 90 years of age group who had femoral popliteal occlusion with CLI symptoms who underwent Supera stenting were included in this trial. They were followed up regularly for a 1-year period via clinical or video consultation, and they also took X-ray imaging to rule out stent fracture. SF-36 study was used to assess the health-related quality of life, and angiographic image was assessed by an independent reviewer to avoid bias. So the primary endpoint was freedom from target lesion revascularization. On Kaplan-Meier curve, you can see it is around 90.3% at end of 1 year. The secondary endpoints were overall primary patency, which was 89.2%. It is seen more as in patients who are claudicants, in patients who are non-diabetics, and who had a normal deployment of the stent with 10% of compression or 10% of elongation of the curve. Around 92% of the patients had improvement in the Rutherford staging by more than 1, and the quality of life has improved by 110% over a period of 1 year. There was no risk of stent fracture seen in this study. The freedom from all-cause death was 90.58% at the end of 1 year. In this study, they also noted that there is strong adherence to the platelets, especially more with dual antiplatelet therapy. And they also conducted an external comparative analysis and showed similar patencies with Gilbert PTH tail and Sorocos Martel, etc. This study being distributed across India has a diverse population, so it is more vulnerable, had multiple endpoints, especially including the quality of life, which is not seen in various prior studies. The limitations being the study being a single arm had no control. The study may have the risk of selection bias, and since it is a short-term study, long-term study is required to understand the long-term patencies and outcomes with Supera stent deployment. So to conclude, Supera stent showed higher freedom from target vascularization and better primary patencies and better quality of life. So it can be considered as a primary choice for endovascular treatment of femoral popliteal occlusion. Thank you.
Thank you, Dr. Shashidhar. This is a very well-run registry of 20 centers, and there's some quite senior authors on the publication. It's a cohort of predominantly claudicants, if I'm not wrong, and the 12-month health-related quality of life outcomes and patency outcomes are excellent, but do you think that 12 months is a sufficient follow-up for this group, the non-critical population?
No, we need a longer follow-up, maybe 5-year follow-up for better understanding of the stent works. Because we do not have a place and affect within 2 years. So better understanding will only be there if you follow up for longer time.
And with regard to the elongation of the stents, was there any subgroup analysis of the patients with that, or the inappropriate elongation?
They said in their study around 10% compression and elongation, they had good patency, but if it is extending further till 40% compression, so poorer primary patency. But overall, it is around 89%.
Martin Bjarke, can I ask you, what would you consider the best outcome measure when treating claudicants?
Among these, I think Wester's primary patency is in this study, which is the better.
But is it primary patency that you aim at when you treat the claudican?
Claudicans we aim at improving the walking distance and quality of life. So,
And were you satisfied with those results in 12 months?
for 12 months, yes, sir, but longer follow-up is needed.
Hi, Dr. Sakshida. Can I ask you, how was primary patency defined? Did you bring back all the patients for an angiogram at 12 months and then it's an angiographic assessment? Or how was it defined? And the second question is, do you know what was the indication for stenting? What was the decision behind application of Supera stents for this cohort of patients?
These patients were followed up by at the end of 1 year with angiographic evaluation to look for patency and also to rule out fracture. The other question is considered only for de novo.
Yeah.
So in the study, the patients who had number of operational lesion, significant stenosis or occlusion were considered for stenting. With 30%, stenosis more than 30%.
Are you aware of the claudical screening or the CMPI?
I don't remember the exact distribution of in the study.
Maybe I could just comment on that. We have recently published publication standards in the European Journal of Vascular Surgery, where we insist that in studies like this that you separate critically threatening ischemia patients from claudical patients, because mixing them makes it really difficult to understand the outcome of this study. So that could be for the future, maybe something.
I think that would be a relevant point. Welcome, Asha. Thank you, sir. Thank you.
Dr. Asha Johnson from South Africa. Hi, ma'am.
Thank you very much.
The next we have Dr. Suraj Ambre, present his study.
Good afternoon, everyone. I would like to present a study, a comparative study of an outcome between a single vessel and a multi-vessel intrapopliteal angioplasty in patient with a chronic limb-threatening ischemia. The study was conducted by Dr. Hemant Chaudhary and Vijay Kandan, KP Sumanand Praji. The aim of the study was to compare the outcome, that is primary outcome, that is limb salvage and wound healing in a patient with CLTI who has undergone single vessel or a multi-vessel angioplasty. So this is a single-centered prospective non-randomized study. The study involved 143 patients with CLTI with Rutherford category 5 and 6. In single vessel group, we included 91 patients, and in multiple vessel group, we included 52 patients. So the inclusion criteria with patients having intrapopliteal disease with single or multiple vessels. In exclusion criteria, we had prior PEMPOB reaspiration were done, any reaspiration done, lost in follow-up cases, a patient who died or with technical failure, they were excluded from the study. In the primary outcome, we're looking after the limb salvage and wound healing. In a single vessel group, the limb salvage after 6 months of the follow-up, the patient has 93.5% of limb salvage in single vessel group, and in multi-vessel group, 90.7% limb salvage. The wound healing in single vessel group was 70.1%, and in multi-vessel group it was 62.8%. The healing time of the wound in single vessel was 108 days. With multi-vessel group, it was 83 days. It was a significant outcome for a healing time in a multi-vessel group. The secondary outcomes, we're looking for the ankle brachial index, toe brachial index, and transcutaneous oxygen pressure, which showed that almost all the parameters were comparable with just transcutaneous oxygen pressure increase at the 1 month after angioplasty and multivessel group. Other outcomes like plantar arch quality, major adverse cardiac events, and mortality were all comparable. Clinical implication, choosing multivessel angioplasty may accelerate the wound closure and early perfusion without increasing any risk. But at the end of the 6 months, the final outcome is almost equivalent for both the strategies. So decision about to go for a single vessel or a multiple vessel depends upon the technical feasibility, the anatomy of the vessel, and the patient's healing goal. The conclusion is the multi-vessel intraocular angioplasties are associated with the shorter wound healing time, but no effect on limb salvage and wound healing rate at 6 months.
Okay, perhaps can I start with, can I ask, when you discuss limb salvage and wound healing, I suppose, and you've got two comparative arms there, one is single vessel, one is multi-vessel. I think it would be important to know the baseline characteristics of these two groups of patients to try and make sure that they are as comparable as possible. So can I ask, in your opinion, what baseline features are important for us to know, so that at least we know that those two groups are at least comparable?
We have excluded all the patients having PEMPOP disease or any other vascular intervention, infra-inguinal vascular intervention were there, or any failed intervention before this procedure, and we have included patients with the category 5 and 6 having ulcer over the foot. So we've taken all the patients having mostly the operative disease only, with single or multiple vessel disease.
So was it comparable in terms of the risk factors like CKD, diabetes, because outcomes can be different in some patients? So whether it was comparable or not?
We have taken into consideration the comorbidities also, like diabetes, CKD. Patient were not randomized. We were not randomized. Patients were having all the comorbidities also, like diabetes, CKD, and CVA.
What about the size of the wounds and Wi-Fi scores? Do you have any data on that to see if there's any difference between the two groups?
So almost both group patients were having Wi-Fi scoring of 2 or 3. So mostly patients having deep ulcers over the heel, with exposed tendons, with infection, with involving subcutaneous tissue very important.
May I ask you, do you think that the difference between the groups were on the surgeon or operator who did the intervention, who had different strategies of treating multiple vessels or single vessels, or are there differences between the patient characteristics?
This study was actually organized in one institute. Different vascular surgeons were doing on it and have a different strategy on working on the vessels. This was not randomized. This was biased in a study that all surgeons have their own strategy to deal with the vessel if they want to correct for the single vessel or multiple vessels. So this was biased in the study.
So the decision to treat multiple vessels versus single vessels, was at the discretion of the operator? Do you think that the ease of performing multiple vessel revascularization would have introduced a bias to the two arms of the study? The ease with which the proceduralist was able to perform 2 vessel revascularization, might that have been a selection bias in the outcomes of the study?
So he is saying that the ease of doing the second vessel could lead to a bias in the study for the operator. Have they pre-decided, or was it the ease of doing the procedure that
It
time?
was decided on the basis of the anatomy of the vessel and the wound, and where the if the targeted vessel is present in the aneurysm of the wound or not. Depends on that, we are deciding to multi-vessel angioplasty should be done on.
Basically, angiosomal control. Okay, thank you. Dr. Sudhir Reddy.
Good afternoon, everyone. Good afternoon to the international faculty and faculty here. I'm Dr. Subir Reddy from Hyderabad. My manuscript of my pitch is about longitudinal versus transperitoneal incision in elective cases of open repair of abdominal aortic aneurysms. This is a retrospective single center study which was done in 52 patients. 26 patients belonged to the longitudinal group and 26 patients belonged to the transverse group. The exclusion criteria were ruptured AAA emergency cases, retroperitoneal and aortic aneurysms which were approached through retroperitoneal, and the patients who had prior history of abdominal surgeries. The endpoints of the study were ventilated duration, ICU stay, the postoperative ileus and analgesia needed, and the hospital stay. This was a retrospective analysis done in January 2021 to January 2022, June 2022. The parameters and the key outcomes were the prolonged ventilation, which was considered the patient who was intubated beyond POD1 was considered for prolonged ventilation. The ICU stay, the postoperative ileus when the patient was not allowed, could not tolerate oral fluids beyond POD3 were included in this. And the IV analgesia was the same for the patients. It was a mix of bupivacaine and fentanyl. The mean hospital stay, in this key outcomes, where we could see is the postoperative ileus and the mean hospital stay, there is significant value and the conclusion of this study is the prolonged ventilation, ICU stay, and the IV analgesia were comparable. The conclusion of the study was the transverse incisions are associated with lesser postoperative ileus and shorter hospital stays. Branchrow and Roseburg, one of the randomized control trial, also supports the trial of the outcome in which the transverse incisions were better, but they preferred longitudinal incision in cases of ruptured AAA cases and emergencies. And a complaint review compared, but they told me that both the incisions had equal outcomes, and it just depended upon the surgeon's choice. The clinical implications are to consider transverse incision for elective open AAA repair to potentially reduce the complication for the patient and the hospital burden of the patient. My limitations for the study would be, this is a retrospective study. A more prospective study could enunciate the objectives of this study better. And the small sample size in which the incidence of the postoperative ileus and was only one, which would not be sufficient to attribute it to the general population. And the duration of the study was only for 30 days, which is immediate outcome, and it was not a long follow-up. Thank you.
Thank you. I ask a question? Thank you for your presentation. I just want to ask, did you differentiate what type of abdominal aortic aneurysm was this infrarenal, juxtarenal? Because obviously that will influence your access. Was this part of your subgroup analysis?
Ma'am, the type of aneurysm and the surgeon electing the transverse or longitudinal incision was not mentioned. Why? Why they took this longitudinal? In which type of aneurysm what was taken was not mentioned in the study.
May I ask, did you use post-operative epidural anesthesia in these patients?
Yes, sir. Post-operative epidural anesthesia with bupivacaine and fentanyl was used.
In all patients?
In all patients.
And may I also ask you, what would you expect any difference in the long-term outcomes in these approaches?
So in long-term outcomes, pain was low, or visual on a pain scale would visual on a pain scale was not done in these patients because it was a retrospective study, because we could not. But in long term, the people who were facing a longitudinal incision would have more complications of pain compared to transfer.
And maybe I phrased my question not clear enough. Of course, you only studied 30-day outcomes, but if you had studied 5-year outcomes, for instance, could there have been any difference between these incisions after 5 years?
After 5 years, I could not. I mean, it would not be much difference.
Would you expect? There is actually, for your information, there are studies showing that there are more hernias after transfers.
Incidence of hernias and incisional hernia incidence is more in the longitudinal group compared to the transverse.
The other way around, there are less incisional hernias after transfer.
And was there any mesh used in any of the abdominal closures?
So the usage of this mesh was not mentioned in the study.
Did you perhaps look at the operative time for each of these procedures and compare them between the two groups?
So the operative time was just mentioned as it was almost same for both the longitudinal and transverse groups.
Can I ask, how do you define post-operative ileus?
Well, post-operative ileus is defined by patient not having bowel sound, and he was not able to pass the platters beyond POD in the study, and was not able to tolerate the oral food. Thank you.
Thank you, Dr. Sudeep. Next, we'll have Dr. Prashant Jain.
Good afternoon, everyone. I'm Dr. Prashant. Today I'm presenting a visual abstract of topic new classification for juxtarenal aortic occlusion based on imaging for safe clamping and contemporary surgical management. This study was conducted by Dr. Savlania et al. In 2022. The objective of the study were to decide the site of aortic clamping and based on preoperative imaging and intra-op findings, and to assess the midterm follow-up outcomes in patients with juxtarenal aortic occlusion. The methods, there were total 40 patients enrolled in the study. It was a retrospective single-center study. Mean age was 53.9 years and 97.5% were males. Procedure done was aortobiofemoral bypass plus minus SMA bypass. The inclusion criteria in the study was patients whose thrombus was extending till the ostia of the lower renal artery, and exclusion criteria was the patients who had any cardiac or pulmonary comorbidity, not allowing them to undergo the procedure. Mean follow-up was 26.7 months. Post-operative serum creatinine levels were compared with the renal ischemia time. And as we can see in the image, patients were classified into three types, type 1, 2, and 3, and based on the level of clamping, whether interrenal, suprarenal, or supraceliac. In the results, average renal ischemia time was 16.8 minutes. And there were two perioperative mortalities, one due to myocardial ischemia, another due to AKI and requiring hemodialysis. Perioperative morbidity was 22.5%. graft patency and limb salvage rates were 100%. And as we can, according to studies, significant positive correlation was found between the clamping times and post-operative serum creatinine levels. As we can see in the table, the patients who had a clamping time of less than 20 minutes, they had better serum creatinine levels at post-op day 1 and 2 and 3. And patients with renal ischemia time exceeding 20 minutes had statistically significant rise in serum creatinine at post-op day 1 and 3 with the p-value of significant p-value. So in the conclusions, based on a simple classification technique and good pre-operative planning, safe intraoperative clamping times can be decided to reduce the risk of renal ischemia. In limitations of the study, we can say that it is a retrospective study. Then the sample size is small and the study needs external validation. The classification needs external validation to be applicable on a bigger population. And this is
Hi, maybe I'll start. I'm not sure if I've missed it, but so in terms of clinical application from your study, what would be the clinical application or recommendation based on what you know?
Sir, according to this study, based on the preoperative image and intraoperative finding, we are deciding the level to which the thrombus is progressing. Whether it is limited to the lowest renal artery, in which case patients line type 1, intrarenal clamping is done. Whether it is going and involving both the renal artery ostia, so suprarenal clamping will be required in those cases. And in many patients, the thrombus extends along the posterior aortic wall till the level of the SMA ostia. In those cases, if we apply a suprarenal clamp, then there will be inadequate clearing of the thromboendarterectomy and inadequate clearing of the thrombus. So in those patients, supraciliar clamping which is a type 3 according to this classification. So this classification just simplifies the way how we see the thrombus and the level of clamping for better operative outcomes and reducing renal ischemia.
And for those more complex ones that require a higher level of clamping, do you recommend anything preoperatively to try and reduce the amount of kidney injury postoperatively?
Sir, in this study, the authors have used intraoperative mannitol in all the patients before the clamping. 100 ml 20 gram mannitol was given in all the patients, and then under vision they have tried to remove the thrombus, and then third thing, they have always led to the back bleeding of the renal arteries before and clamping of, then followed by clamping of the renal arteries before shifting the clamp infrarenally, so that no arterioemboli goes into the renal arteries.
It seems to me that there's no comparator group where this classification hasn't been applied. So do you think that the conclusions of the paper that this perioperative planning and use of the simple classification does in fact improve results, or is it just it's just a series with very good outcomes?
So definitely it is a single institute result. That is why this classification needs external validation. How it performs in the other population groups and other institutes. Well,
Thank you.
Time is over. Thank you, sir. Thank you.
Good afternoon.
I'll be teaching the article outflow vein tributary access for central vein cephalic arch angioplasty in disruption of AVF, the unconventional technique. The conventional technique of central vein and cephalic arch angioplasty involves an access taken to the AV fistula or femoral vein or internal jugular vein. The objective of the study was to assess the feasibility and clinical outcomes of central vein and cephalic vein arch angioplasty using an outflow vein tributary access. The study was a prospective interventional study done in 2 tertiary care centers between January 2023 to December 2023 with patients with AV fistula and central venous stenosis. A total of 34 patients were involved in the study. The new technique involved the use of ultrasound to screen the vein and find a suitable tributary vein of 3 to 4 millimeter and to find the angle of the vein, angulation of the vein. And it was followed by ultrasound guided access with 5 French sheet, and it was serially dilated up to 10 French sheet depending upon the need for the materials to be used. The results of the study, most of the patients, around 75%, had multi-segmental disease in innominate vein, subclavian vein, cephalic arch and innominate vein. 1 patient had lesion in the superior vena cava, 7 patients had disease in the cephalic arch. The technical success rate for the procedure was 88%. In 4 patients, in spite of taking an extra access also, the procedure could not be done. Out of the 13 successful patients, in 23 patients, the entire procedure was carried out through the tributary vein access only. And in 7 patients, 1 extra access was taken to finish the procedure. There was no access site complication. During the follow-up period, at 6 months, 1 patient had recurrent stenosis, and the tributary vein access was used for further angioplasty. The conclusion, the use of tributary vein access appears as a safe and effective approach for central vein angioplasty. It avoids the complications of direct AV fistula or femoral access. It also supports the use of wide bore sheath up to 10 French, and it maintains the integrity of the AV fistula and also allows the same dialysis on the same day. The limitations of the study, it's a small population only is included. It won't be not feasible in patients who don't have a adequate diameter of the tributary vein, and unfavorable vein angulation is also a limitation of this study. The novelty of the study is this is the one among the first studies which has taken into assess the tributary access as access for the central vein of cephalic arch angioplasty. Only limited data is available. This procedure for this access appears to be a viable and safe access strategy for central vein and cephalic vein angioplasty, but a larger population study is required to validate this.
Thank you for your presentation again. Can you tell me what were the reasons for the technical failure that you mentioned in, you said you had 88% success rate. What were the 12% reason for failure?
They were not able to cross the lesion in spite of taking an extract.
Can I ask which type of AVF is suitable for this? Is this presumably for Vsi AVF?
In this study, they have only included the cephalic AVF stuff.
Okay. And what do you do about anastomosis in the about stenosis or lesions in the juxtaanastomosis when you use this access?
We won't be able to address the juxtaanastomosis lesions in tributary access.
And so, how many in this cohort of patients? How many patients had anastomotic lesions, and how did you deal with those?
Sir, in this study population, patient had lesions in the cephalic arch, innominate vein, and central veins. Not in the juxtaanastomotic patients were not included.
And could you give us an indication roughly of all the dysfunctional AVFs, Vsi AVFs, how many would be suitable for this type of access?
we don't have an exact data about the tributary vein access because studies are less. So further studies are required to assess what is the incidence of tributary access.
Was there any comment made in the paper about the preservation of those tributaries that were accessed? Do some of them occlude, or do some of them get hematomas and are not utilisable in future, or change the venous drainage from the fistula?
Follow-up screening of the tributary access was not done, but in one patient who had recurrence of symptoms, the same tributary was used as an access for redo procedure.
Was there any mention about what is the advantage of using a tributary versus puncturing the vein?
The puncturing the vein, there is 1 to 2% chances of risk for the fistula, like hemorrhage, pseudoaneurysm, compression causing AV fistula thrombosis. So, taking a tributary access, any complication has the fistula won't be affected. Plus, the same day we can do the dialysis with the same fistula.
Can I ask you then, based on what you know about this access method, when we create the BCABF, would you advise for us to, sometimes we will ligate the branches in order to let the BCABF mature better? So should we be ligating these branches, or should we be leaving all these branches alone in that procedure?
We should be ligating the branches in the initial procedure. When central vein stenosis happens, we have to screen and find whether there is a tributary access available. Thank you.
The question in the end. We'll have Dr. Suma Valli.
Good afternoon, everyone. I am Dr. Sumawali from Yashoda Hospital. Today I will be talking on antegrade access for peripheral vascular disease intervention of lower limb at a tertiary center. It is a single center observational review study conducted between 2014 to 2021. Included 482 patients. They included patients who underwent intra-inguinal revascularization with antegrade access. They excluded the patient who need suprainguinal intervention and who has a history of previous interventions. The aim is to study the antegrade access technique, to assess safety of this technique, and to assess merits and demerits of this technique. They don't have their own comparison group here, so they compared studies of like Pizzold et al. And Blumberg et al. Studies with their contralateral retrograde access data. The results were the complications associated with the antegrade access were lower, like hematoma formation, pseudoaneurysm formation, dissection, and distal embolization. Fluoroscopy time also less. Contrast used was less. Radiation exposure also less when compared to the retrograde axis. Finally, they concluded antegrade access for peripheral vascular disease is a safe, effective option with fewer complications, lesser utilization of the fluoroscopy, and with lesser contrast usage. The limitations of this study are, it is a single center study. They did not have their own comparison group, and they did not mention the distance of the disease from the puncture site, and they did not mention procedural success rate and their outcomes. And patient demographic details are also limited in this study.
May I ask you what was the complaints, what the pathology of these patients? Were they claudicants or did they have critical limb-threatening ischemia?
These patients are all presented with rest pain, for class 4 and class 5 patients.
Was there any mention of the use of point-of-care ultrasound for the guidance of the puncture? And was there any differential in the size of the sheaths used between the antegrade access and the contralateral access?
They have done antegrade puncture under the guidance of ultrasound or fluoroscopy. And sheath, they didn't mention anything about the sheath in the study.
Were they making any mention of the use of closure devices for these procedures, either retrograde or antegrade?
I didn't get you, ma'am. Can you repeat?
Did they mention whether closure devices were used during these procedures?
If they use 6-10 sheet, they use closure device. Below 6-10 sheet, they have applied minor compression.
As per the comparison data, do you think it's a nice habit to have with the published study or your own center, because your expertise will differ from what is published? You can have a selection bias in that also. What would you recommend?
Yes, sir. Antegrade puncture is
Comparing a study in terms of a research paper, not the study itself. The study has been compared to a published paper, which can be having a data which you are selecting because of a reason.
If we compare the study with our own institute paid people, it will be good. We have, because the protocols will be similar in both the groups. So the outcomes will be visibly comparable.
Just one study comparison can be flawed. You can take a meta-analysis or a bigger group, but just one study with one center, they can be different in terms of selection bias. Any further questions, Dr. John? Dr. Jackson, sir? Okay. Thank you. We move on to the next paper by Dr. Basmaraj.
Good afternoon, everyone. I am presenting a visual abstract from one of the articles published in the year 2019 from one of the tertiary centers in India. So the study was a comparative study on a patient presented with grade 2B acute limb ischemia. So they basically tried to predict whether time of presentation is an independent predictor in limb salvage or not. So and the study design they used was a single center retrospective cohort study. Study population was patients with a grade 2B acute limb ischemia between time frame of 2015 to 2017, and it was a single center study. Study sample was 51. So, and then the inclusion criteria were class 2B acute limb ischemia and who underwent a revascularization procedure, and patients of more than 18 years of age. The exclusion criteria was patient who had a prior vascular intervention done, traumatic or iatrogenic etiology, and patient who lost to follow. And the baseline data parameters were as follows. The age was around 49 years in both the groups, and most of the patients were males in both the groups. And the level of occlusion, almost everybody had femoral-popliteal occlusion, while 23% in the delayed presentation group has aortic disease along with femoral-popliteal, and 25% had a tibial disease along with aortic. So these patients did not have any comparable significant difference in the baseline data, and the comorbidities were also comparable in both the study groups. So, and patients in the early presentation group had a underwent femoral embolectomy, while 95% in the late group underwent a femoral embolectomy, and along with the femoral embolectomy, 12% required popliteal embolectomy and additional surgical procedures in terms of bypass were required in 20% in early group, whereas 26% in late group. So all the parameters were comparable. The limb salvage rate in the early presentation group was 91.6%, while it was 72.73% in the delayed group. So the point to be noted is the time cutoff that they took was 24 hours of the onset of the symptoms. While the number of amputations, major amputation in early group was 1, that is 8.3%, whereas in the late group it was in the early within 30 days it was 12, while late it was 5. So there was no significant difference in both the groups. The authors concluded that despite the delayed presentation, limb salvage can be done. So there are limitations of the study. So in the authors did not mention the review committee or ethical committee approval, and arbitrarily chosen 24 hours. Both the groups have crossed the window period. And there is a selection bias because they missed the grade 3 acute limb ischemia patients. which have progressed from grade 2B to grade 3. So this satisfies selection bias. And sampling technique is not mentioned. Small sample size, external validity is questionable. Comorbidities were not quantified. Absolute risk reduction and relative risk reductions were not commented on this. Cause of mortality was not accepted. Explained in this.
May I start asking you, were there any problems in defining Rutherford class 2B? The reason why I asked that question is because we have had experience in investigating acute limb ischemia that there's not a clear distinction between 2A and 2B, and actually not between 2B and 3 either. And that this old Rutherford's definition may actually need to be revised. Do you experience any problems in that?
Yes, sir. So particularly so with the patients who are old age and diabetic neuropathy. So so since neuropathy can add on to the confusion with whether patient has a 2A or 2B, and grade 3, and there is no clear definition that even in grade 3, some of the times patients who have a foot drop, when we do a fasciotomy, we find that the muscles are reactive. That's not exactly a dead limb. So we do have faced these situations of confusion between 2A, 2B, and 2B3 as well.
I may have missed it in your summary slide, but was there a difference in the rate of fasciotomies and also take back for further debridement because of myonecrosis between the two groups?
Sorry, sir, I didn't get the question. Yes,
Was there a difference in the rate of fasciotomy?
No, sir. No, there's no statistical significant difference. Around 50% of the patients in early group had a fasciotomy, while 46.34% had a fasciotomy. However, further debridement data has not been mentioned in the studies.
So you divided your threshold for early versus late into 24 hours. And can I ask for the late revascularization or late presentation? What was the range of the timing to presentation? What was the latest and what was the earliest? And was there any further difference in limb salvage between those that are really, really late?
So that data is not available, but earliest was 3 hours, whereas late went almost up to 1 week of presentation.
And what was the etiology of the acute limb ischemia? I think that the reason why I asked that is because the etiology can also make a difference to the limb salvage rates.
So that the pre-existing vascular status of the patient is actually missing. I mentioned in the limitation that what was the collateral status, whether presence of chronic disease was not mentioned. So that could have made a significant difference in the outcomes of the study. And what they have given is most of the cases had a thrombotic cause. Embolic was only around 5% of the patients was what was mentioned by the authors.
Did you find that there was a significant difference in the complexity of the revascularization procedure that was required between these two groups?
No, ma'am.
Saying that that's some of the delayed presentation might be a more organized thrombus already. Did you find any difference in how complex these cases were?
Yes, ma'am. If we see the number-wise, only femoral embolectomy was sufficient in most of the cases in early groups. While if you see the data in the late group, though some of the patients, almost 26% of the patients required additional bypass surgery, and around 12% of the patients required popliteal embolectomy. So probably they had a more complicated thrombus or embolic phenomena when compared to early group. Well, because they divided each into individual categories and the numbers are small, so we are not getting any statistical significance. We can combine together, we can make into a single parameter. Maybe we will find a significant difference in both the groups.
Thank you,
So,
just the last question. Generally speaking, is embolism less common in India than in Europe, for instance? Because in Europe, we would expect at least half of the patients to be embolic.
Yes, sir. Embolic phenomena are less common in India. We most often see thrombotic, and usually we see chronic lesion existing and acute on chronic rather than just acute condition.
Thank you.
Thank you. Thank you.
So beyond, I think I would agree with you that embolic is actually quite common in India, though it is not shown in this study.
I see. Thank you for clarification.
Thank you. Thank you, Dr. Vasura. So we have the last presenter for this session, Dr. Ashwitha Ravi.
Good afternoon, respected faculty and colleagues. Today I'm going to present the article on open repair of juxtarenal aortic occlusion in high-risk patients. This article was published in the Indian Journal of Vascular and Endovascular Surgery in 2022. The aim of this study was to evaluate the outcomes of open surgical bypass in high-risk patients that present with juxtarenal aortic occlusion. It was a retrospective study conducted between August 2015 and November 2020. It was a single-centered study that included all patients with juxtarenal aortic occlusions who underwent open surgical bypass. Patients with associated aortic aneurysms or acute occlusions were excluded from the study. And all patients underwent a standard aortobifemoral bypass under general anesthesia and epidural anesthesia with a temporary suprarenal clamp, the renal baggie, after which, after evacuation of thrombus, shifting of the clamp to the intrarenal segment. All demographic data regarding preoperative comorbidities, the perioperative course and post-operative outcomes were noted in this study. So a total of 35 patients were included in the study, which were predominantly male. 34 patients were male patients who presented in a spectrum of PVD, including intermittent claudicants as well as CLTI. We'll notice here that the median age of the patients was 56, ranging from 35 to 74 years of age. What is important to note in this study is all patients had some sort of risk factor comorbidities. More than 90% of the patient cohort had smoking or hypertension. About 71% of the patients had ischemic heart disease. 50% of the patients suffered from diabetes mellitus, and 1/3 of the patients had COPD. 3 patients included in the study also had pre-existing renal dysfunction. During the procedure, 7 patients, which is 20% of the patient cohort, also underwent sequential intrarenal bypass along with the standard aortobifemoral bypass. 1 patient underwent mesenteric bypass, and 3 patients had an additional renal artery revascularization during the procedure. We will note in the outcomes that there were no perioperative mortalities in the first month following, within 30 days of surgery. Although 9% of patients had myocardial infarction, only 1 requiring intervention. 3 patients had respiratory complications. 2 patients had renal dysfunction, none which required hemodialysis. 1 patient had graft thrombosis in the immediate postoperative period requiring re-exploration. We note that the graft patency was 93.4% in the follow-up. In conclusion, open surgical bypass is the treatment of choice for juxtarenal aortic aneurysm in where patient optimizations can be done and there is in-street exclusion.
And you mentioned that you included patients with complication as well as CLTI. And in one of the previous presentations, we did ask, did you do a subgroup analysis? I know you've got a small patient cohort, but did you compare these patients?
No, in this study, a separate analysis of CLTI and claudicants was not done. It was there were only 35 patients in the patient cohort, so a separate analysis has not been done.
Can I ask, what was the proportion of patients that required suprarenal clamping for this procedure?
So all patients underwent a temporary suprarenal clamping in this study. After creating proximal clamp space, temporary suprarenal clamp and taking renal control, a temporary suprarenal clamp was placed, and the thrombus material was evacuated. And following, after we checked the renal backbeat, the clamp was then shifted to the intrarenal position.
And can I ask, is this a single center study? And if it's a single center study, what was the proportion of endovascular procedures for this type of lesions?
In this center, usually for juxtarenal endovascular is not useful.
Do you think that this publication would be likely to change the practice of a lot of vascular surgeons in India based on the result?
Currently, it is an endovascular era where more and more endovascular procedures are being done. But the outcomes of endovascular procedures in juxtarenal still don't reach the same as open bypass surgeries in juxtarenal occlusions. So if a patient can be optimized adequately and and we have a good institutional experience, going for an open surgical bypass in such patients might provide us better long-term outcomes.
Thank you.
So with this was the last presenter for this session. Some disclaimers to make here that these presenters were not the authors of these studies. They chose these articles. We had given them a bank of 15 articles based on a screening test that we had done yesterday. So out of those, the top 10 chose what they will pitch to these judges, and we had a magnificent international panel. We are very proud that this interaction could take place, what we have visualized months before. And thank you so much, Dr. Cho, Dr. Martin, Dr. Jackson, sir, Asha ma'am, who has spared their valuable time to encourage the students here who were really overwhelmed to present in this session. I believe that these kind of interactions and presentations open their horizon for presenting in ASVS, in ESVS, in South African societies, World Federation societies, and the ANZ, that, we get what is expected out of these students, because these are the future of the Vascular Society of India. We have a motto from the society and the journal that we have. We have married them both together so that, we are having these events from the journal in our midterm meeting. This is a student-centric meeting, and hope that these bright minds of today become the leaders of tomorrow internationally. Thank you so much, all the people present here. I would like to call upon the panel of the journal here. Dr. P.C. Gupta, Sir, Shiva, Himanshu, and Pandey, if you can come over the stage. We'll have a combined group photo with the international judges to kind of highlight this session.
Professor Brock, once again, apologies for the miscommunication regarding the time. It's something nice to share. I think I must congratulate you on getting that very significant jump in the impact factor for EJBS, and I think it is also enthusing us to get our journal in a much better shape. And I think such interactions will definitely help us in improving the overall quality of publication that we get for the journal. And thank you, Eddie, and all the best for your ASPS meeting. And I'm sure a lot of people from BBSI will be attending your meeting. And thanks, Mark, and all the best for your meeting in coming October. Unfortunately, we will not be able to attend since we will be having a meeting almost on similar dates. And Asha, thanks a lot, and we look forward to working with you for the forthcoming guidelines for CLPI. Thank you very much for being part of this.
We can end the session. It was a very close to the heart session and very overwhelming. Let me tell you all that we really enjoyed what you guys presented. So we move on to the next business for the day. We are running short by 20 minutes, but we'll try to cover up. We have the extempore presentations for the third years. I think they are ready with their kits, and would like to call upon the judges and the team leads and scorers for this session. Dr. Ilan sir, Dr. Sharmila ma'am, Purnima and Vji Vikraman, you kindly take the session lead. Ilan sir is just joining. Dr. Vikraman is here. Dr. Vji Vikraman. Hi, Ilan sir. We have Dr. Nihal Ranjan Pradhan sir, Dr. Sharmila Suresh ma'am, and Dr. Ilan. So, Purnima, please.
For example, you get 2 minutes to prepare. That's what we told. So the next thing now will start after 2 minutes. Data is to say. Data. No. Data. If it's not there, we might jump to the last session. Data. So we mark the time now in the next 2 minutes. The next day, we keep the date. Line किधर दिख रहा है? इसके पीछे अभी देखा देखिए देखिए 4 minutes is okay for you or 2 minutes? 4 minutes. So we'll make it 4 minutes. The moment after it goes, you have 4 minutes. Okay? और देखना by 4 minutes you have time. So the next day, make it a video. So this comes from Purnima. We are ready for
चार्जिंग करना होगा ये खराब हो गया क्या बोल रहा है छुट्टी उड़ाएंगे उसमें नाम होगा वो बात करने वाला उसको कौन वाला है ना कौन वाला
The first speaker will be Dr. Chaitanya. His topic is aortic clamping, hemodynamic consequences and protective strategy.
My topic is aortic clamping and aortic clamping is a critical component used in many vascular surgeries, including thoracic and aortic aneurysm, as well as in many trauma surgeries. And because of that, major hemodynamic consequences and physiological effects. And there are types of aortic clamping, including supra clamping and infraclamping and supra. The hemodynamic consequences because of aortic clamping, they include the proximal hypertension and ischemia, and the metabolic consequences because of lactic acidosis. And because of the increase in cardiac overload, which leads to ischemia and hypertension. And the physiological effects, clamp on response and clamp off response. The clamp on response, it leads to increased cardiac load, and which leads to arrhythmia. And clamp off responses to limit the gradual declamping. There is hormone-based related events on this clamping. Cardiac events, as already told, increased cardiac action load, and renal effects for the acute kidney injury and on clamping. And in the Supera, effective clamping and ischemia also leads to power to hand organ. So to limit these consequences, gradual clamping and declamping should be done.
जहाँ रुके वहाँ बहुत अच्छा
So, what are the how much percentage of load increases for cardiac when you are clamping aorta, when you are clamping iliacs, when you are clamping femoral?
The more particular increase proximal
percentage of
We wish to know the percentage because more this it is not done. We are not aware of this. And similarly, similar to that question, is there any difference in the renal perfusion in the Supera aortic clamping and infrarenal aortic clamping? If so, what is the percentage? You were repeatedly talking about slow deep clamping and clamping. What do you mean by that?
Gradual clamping is done to avoid these.
Yes, what do you mean by gradual deep clamping?
To allow these to flow.
How will you do it?
In the clamping time they are speed. So if the clamping time is more, what frequency will take? So in case of aortic occlusion, how will you, what is the sequence of declamping? Aortic occlusion, you are doing aortic bilateral or biiliac, aortic biiliac infrarenal bypass. What is the sequence of declamping? For all of you, what is discussion going on, imagine you are sitting in the final exam, the same way. You know everything you answer.
The next speaker will be Dr. Teja Challa. Topic is non-ischemic monomedic neuropathy.
The main cause of the non-ischemic neuropathy will be due to surgical kinds of function over the nerves or the incorporation or the post-operative period over the hematoma compressing the nerves, either the median or ulnar nerves, and which presents in chronic burning pain with anesthesias in the post-operative period with clinically significant motor deficits and the sensory or motor. It usually affects elderly people with microangiopathies or the diabetic uncontrolled, poorly controlled long-standing diabetic people with microangiopathy. And the diagnosis is by pulling out the NCS and EMG and ultrasound showing no arterial glucose or insufficiency or arterial involvement. We are depending on the symptoms. There are 5 grades for the environment. Non-ischemic monomyopathy, which is asymptomatic, mild symptoms, and moderate severe symptoms, and refractory symptoms with fixed motor activity. And the treatment part mainly is to control the neuropathic pain, and eventually, if progresses, improvement is shown at about 6 to 10 months, and do not likely to be fistula in view of no arterial involvement.
How different it is from a ischemic neuro?
Ischemic neuropathy will be in the immediate post-operative period, the patient will be facing the finger sensation of fingertip pain for pain.
That is getting affected from the nerve. That whole physiology, how does
The vasovasorum of the nerves get involved in the NIMS, or non-ischemic monomeric neuropathy, which causes this neuropathy.
Have you heard of steel syndrome? How that will affect your
What precaution you will take to avoid this problem?
Avoid excessive traction of the nerves, handling of the nerve during the procedure. And homeostasis, hemostasis.
Once it occurs, what is the treatment modality?
Primarily conservative, but neuromodulative analysis to carpenter for a long time.
Just wait. Ask you about steel in AVDC. How you are going to avoid intraoperatively? What are the simple steps you will take that while you are doing a breaking calculation?
Placing antibiotic to the injured muscle not to increase more than 6 mm. And checking on intraoperatively the frequency of the ulnar and radial. That is.
The next speaker will be Dr. Manoj. His title is Live BTK Trial, Impact on BTK Interventions.
Good afternoon. This is live BTK is the first randomized control trial comparing the treatment of the intrapopliteal disease with CLTI, comparing the drug reabsorbable capsules with the plain balloon angioplasty. So in this primary endpoint is major amputation limb event, where they have found that PT is having more primary endpoints as compared to the scaffold. And in secondary endpoints with major amputations with they have found the major secondary amputations events in the secondary endpoints in the plain balloon angioplasty. Where the strength of the study is that this is the first randomized control trial comparing the scaffolds compared with the plain balloon angioplasty. But limitations are they have excluded the severe calcific arteries, which are more common in the intrapopliteal diseases. And the operator was there is a single blinding is also there, and the operator is decided to treat these diseases with the scaffolds and with the plain balloon angioplasty.
You are talking about this. What is it made of? What is the outcome? The final outcome that is here in the study?
The major endpoint of study was the major limb event, which they found that 30% of the patients had more major limb event as compared to the 15% PTA and the scaffold. There is a vascular reduction in the
The next speaker will be Dr. Neeli Devi Krishna Shashidhar. Title is Median Arcuate Ligament Syndrome, Role of Vascular Surgeon.
I will be talking about median arcuate ligament syndrome or Dunbar syndrome. It is characterized by compression of celiac artery plexus by the medial crus of the diaphragm. It occurs most commonly in females and compared to males. There are various theories to explain this disease. So first is because of compression of the celiac artery, leading to decreased blood to the foregut, causing ischemia, but it is not acceptable. The second theory is stealing of blood from SMA due to decreased flow from the celiac plexus. And the newer theory is neurogenic theory, where the celiac artery plexus, celiac nerve plexus around the artery is compressed, leading to decreased gastric motility, increasing pain. So these patients present with complaints of epigastric pain after eating, with weight loss, tooth fear, They also, but diagnosis is not acute, so these patients can be present with history of multiple abdominal surgeries prior to presenting to us. So the diagnosis, first we can get an imaging of an ultrasound where we see there's increasing pre-crystallic velocity of more than 200, and you can also see reversal of blood in the common hepatic artery, and you can also see sometimes post-synaptic dilatation can be seen. The diagnosis is made to CT angiogram or an MR angiogram to look for the site of compression. You can also perform a gastric tonometry test in order to assess the decreased perfusion in the bowel and to assess the reduced perfusion in the bowel. So the treatment these patients involves definitive treatment is decompression of the iliac artery, which is through robotic or laparoscopic approach or open approach. And along with it, previously iliac artery plexus blockage also was used. There, after this, you have to follow up the patient with duplex surveillance, and if there is persistent stenosis, you may have to consider for iliac artery plexus open repair or endovascular angioplasty.
To start with a basic question, what is the, how does the iliac artery take off? Is it an anterior branch or is it a lateral branch? What is the angulation that is taking off? And how does the median arcuate ligament compressing on it?
During development of the diaphragm, from septum transversion it grows, and when it descends downwards, the bilateral median thrust develop on grow downwards on either side of aorta. Sometimes what happens because of this condition, there will compression may occur onto the iliac artery because it first originates just after training artery.
What are the indications for surgery?
You have to rule out all other causes of abdominal condition. You have to look for the non-thrombotic stenosis should be there, and there should be reversal of flow, and should have a CT imaging image proven compression of the structures by the diaphragmatic fibers. Otherwise, it may be patient will recover with symptoms and
how many percentage of patient will persist with the same symptom even after decompression?
How we follow this? How we follow this? You have to repeat the duplex surveillance or follow up CT angiogram. 2 years. Master. Thank you.
The next presenter will be Dr. Narendra Babu. Title is Pelvic Congestion Syndrome, Real or Overrated?
My topic is pelvic congestion syndrome. Pelvic congestion syndrome is defined as a perineal heaviness, pain, and postcoital pain due to reflex or obstructed pelvic or ovarian veins. It's ovarian veins. It usually it is associated with other gynecological disorders. So gynecological consultation must be taken before diagnosis of pelvic congestion syndrome. It is usually seen in young females, and symptoms are pain, perineal heaviness, and symptoms usually increases during the daytime and due to prolonged standing, and decrease on the lying down. And it is rarely seen in males with left-sided varicocele. Coming to the diagnosis, signs on physical examination, we have to see for any tenderness of the uterine, recto-uterine segment, and ovarian tenderness, retroversion of the uterus. Coming to the investigations, invasive investigation, the gold standard investigation is the contrast phlebography. We can take a brachial vein axis or a femoral vein axis using a 4-pinch or 5-pinch catheter. Features suggestive of the contrast pelvic congestion syndrome are ovarian vein reflex, contrast stasis in the gonadal vein for more than 20 seconds, and visualization of pelvic congestion in the pelvic veins. Coming to the management, initially we have to give medication for 6 months, like metroxyprogesterone acetate, and
Daplan 500 mg for 6 months. Surgery involves intervention involves a failed conservative therapy, then we have to go for intervention like oophorectomy, ligation of the internal ileal vein or ligation of the ovarian vein.
Again, to start with the basics, what is the etiology of ovarian vein?
Pathophysiology, there are 3 types of pathophysiology. One is the reflex from the ovarian vein or obstruction to the outflow like May-Thurner syndrome or any local compressive factors like endometriosis, local tumor.
Based on the radiological findings, how would you grade these pelvic conditions?
So, in the presentation, you have mentioned patient develops varicose. What are the other vascular conditions patient may develop varicose?
Nutcracker syndrome also can cause bloodshot. First, initially we will give conservative management for 6 months. If patient doesn't show any compressive symptoms or any compressive pathology, then we can wait for conservative management for 6 months. If there is any compressive pathology, then we have to go for like NAVL or May-Thurner syndrome. We have to go for deep venous intervention and SOS stent. Metroxyprogesterone is there. Metroxyprogesterone is there and Daplan 500 mg BD. Metroxyprogesterone is there 30 mg.
The next topic will be by Dr. Makan Mishra, embolic protection strategies in carotid stenting.
The embolic protection strategies in carotid starts right from the proper patient selection, pre-op planning, post-op, pre-op, intra-op, and post-op precautions, and if it happens, then what to done in post-op period. The proper patient selection involves the anatomy, that is type 2-3 arch, avoid type 2-3 arch, more calcification in arch, torsus, CCA, or tandem lesions, ECA, concurrent occlusions, then the plaque morphology itself, if it is vulnerable, then it should not be done. So after proper patient selection, if the treatment is finalized, CA or CAS, preoperatively patients should be placed on DAPT or single antiplatelet therapy based on the recommendations. Antistatins should be there, and if the emergency surgery is being performed, then loading doses of these drugs should be given. In intra-op period, when we start, like in open surgery, if we are doing, then proper handling of meticulous handling of the tissue should be there. In the intra-operative time, we should meticulously remove the flaps, whatever are there. And in case of carotid artery stenting, first of all, we should heparinize the patient thoroughly before putting the clamp. IC should be first vessel to clamp. We should, whenever we are handling the other tissues, we should take precaution basically to reduce the risk of embolization. Before putting the EPDs, we must decrease the manipulation. We must, if possible, we should place proximal protection devices. If it happens, then secondary thing is we must place closed stent if possible, and post-stenotic dilatation is not recommended. Thank you, sir. Transcarotid artery complications. Then 2 to 3% I'm not sure. Now we mesh replace in distal segment of the internal carotid artery that is there. Normally that is available. Otherwise, pro-diverter of there, proximity protective devices are there. Then distal valve occlusion is also a
What are the studies that is giving you that embolic protection devices are essential? You always practice with PPDs or you don't?
We practice with EPDs. Some trials like EVA, this showed the good outcome if it is being done without the EPDs. Other trials like the Supera trial, it has proven that it is non-inferior to the carotid inductance. So it's recommended whenever stenting is done, the proximal devices, EPDs are used.
What is the role of EPDs in other carotid?
Distal embolization can be protected by EPDs, like atrial embolism we can protect, but there is no such study available now.
Next presenter is Dr. Suraj. Title: Fibromuscular dysplasia in peripheral arteries.
Good afternoon, everyone. Fibromuscular dysplasia is a non-atherosclerotic, non-inflammatory disorder involving the mostly medium vessel arteries like renal arteries, carotid arteries, visceral arteries. Clinical features: patient involving the renal arteries has persistent hypertension involving the visceral arteries causes ischemic symptoms like abdominal pain, post-nasal abdominal pain, vomiting. Carotid artery involvement causing dizziness. The classification for dysplasia is medial dysplasia, perimedial dysplasia, intimal dysplasia, and adventitial dysplasia. For diagnosis, usually go for CT angiography with the for the in treatment aspects. First, we start with the medical treatment. Patient having renal artery involvement, patient is treated medically for giving antihypertensive medication. If patient is not responsive to the medical management, we go for an percutaneous transcranial renal angioplasty.
Dysplasia. How different is its angioplasty comparing to other
Fibromuscular dysplasia shows leaf-like pattern we seen in the fibromuscular dysplasia involving the long segment with leaf-like pattern. In natural disease, irregular calcified pattern will be seen in atherosclerotic disease.
You said that it gives a bleeding appearance or the string of bleeding. Among the string of bleeding, is bead part or the string part, which is the disease?
Bead part.
Okay, then what is the treatment of choice for that? Is it surgical? Is it endovascular?
Endovascular.
So again, in endovascular, is plasty enough or
plasty? Go for the first angioplasty. Wait for the long-term application. on the required amount we go for stent. Would we please use the medical therapy for the patient? Along with that, we will go for antigrade and antigrade therapy, Heparin, and this dual antigrade, like and profitable. And for the patient involving renal artery or antihypertensive.
Next speaker will be Dr. Ashik. Title: Strategies for Preventing and Managing Renal Dysfunction After Contrast Exposure.
Good afternoon, everyone. My topic is contrast-induced, reducing the contrast effect after in renal dysfunction. The main thing by using contrast is contrast-induced nephropathy as well as contrast-associated acute kidney injury. It is defined as increasing serum creatinine more than 0.3 milligram per deciliter or more than 50% from the baseline. The risk factors include chronic kidney disease with eGFR less than 60 milligram per minute per 1.73 meter square or increased age more than 75 and that associated diabetes as well as other comorbidities and contrast volume as well as dehydration can also induce contrast associated renal dysfunction. The main management in reducing the contrast effect is good hydration prior to the contrast. Make sure there is good hydration and use low or isotonic solutions to hydrate the patient. Stop any nephrotoxic drugs if there is any increase in renal dysfunction, and we can start with NSPL system and statins to reduce the contrast-induced nephropathy.
So, first, what are the precautions? Your topic was the strategies. So, what are the precautions you will take? Planning for an angio.
Basing serum creatinine.
You will see that. Agreed. Strategies.
Good hydration.
Okay.
Avoid nephrotoxic drugs. Avoid use low molar contrast agent.
When will you start? When will you end? Your strategies. When will you start your strategies? When will you end?
3 hours prior to contrast, we have to give isotonic solution with 1 milligram per kg body weight, and we can use sodium bicarbonate with 3 ml per kg body weight 3 hours prior to the contrast.
You were talking about N-acetyl system, isn't it? What is the dosage? And if you're planning for an emergency, a CT angio, how will you do it?
The dosage is 600 mg CID.
How long? How long prior to CT? How long prior after CT?
What is the evidence, grade of evidence for giving N-acetyl system for contrast nephropathy? That's a proven good grade of evidence. 1, 2A, 2B, post diabetes will be your treatment.
Okay, good hydration, sir. Then start down NSL system, C4 oliguria, and do not expose to further contrast exposure within 48 hours.
Patient is having
we have
Next speaker is Dr. Sudhanshu Goyal. Title is Spinal Cord Ischemia Prevention in Thoracoabdominal Aortic Repair.
Good afternoon, respected diet members. So my topic is spinal cord ischemia prevention strategies in thoracoabdominal aortic aneurysm repair. It is one of the most serious complications of thoracoabdominal aortic aneurysm repair, presenting in up to 15% of the patients. So the prevention starts from the adequate planning of the procedure. Pre-operatively, those patients who have circumferential thrombus, they are at a lower risk of developing spinal cord ischemia because they have already built up a collateral. Patients presenting with acute dissections, acute aneurysm, acute presentations, they are at a higher risk. In pre-operative imaging, we have to look for the like the larger spinal arteries, like artery of the Adamquites, or these are the special arteries which we have to consider for reimplantation if we are going for open repair, or when we are planning endovascular repair. We should go for staged repair so that we give adequate time for the collateral circulation to develop. Apart from that, these are all the pre-operative. Intraoperatively, we have to maintain systolic blood pressure of more than 90. We have to keep the CSF pressure of less than 10 millimeters of mercury. And relative hypothermia is one of the strategies. If we are going for open repair, we have to keep the cross clamping time to be minimum. So these are the strategies. And if we are going for endovascular repair, so the extent of the stent graft or extent of the aortic coverage is very important. The risk factor is more than 150 millimeters of stent graft placement in a single setting. It's one of the risk factors for spinal cord ischemia. Thank you.
What are the two procedures where the incidence of spinal cord ischemia is high?
In thoracoabdominal aneurysm open if we are going for long segment aortic coverage, so in TVAR, because we are covering the
Proceeds from what level to what level we put a stent now? Can you more chances?
At T10 level, if we are covering artery of Adamquites there, which is one of the major vessels supplying the spinal cord. So if we are covering that, and that is one of the reasons. And the extent of more than the length of the endograft is also one of the important risk factors. In acute
What frequency will it take to treat customers?
Sir, first thing we will take is we will keep the length of endograft to be as short as possible. Second thing is we will look if we are going for open repair, then we have to reimplant the intervascular and the lumbar artery. Apart from that, we would, if we have to go for extensive aortic coverage, then I would like to do it in a staged procedure.
Next speaker will be Dr. Krishna Prasad Yadav. Title is Vascular Closure Devices, Innovations and Clinical Perspectives.
My topic is vascular closure device. Vascular closure devices achieve effective and rapid hemostasis after a percutaneous arterial access. There are two types of vascular closure device. One is active vascular closure device and passive vascular closure device. And indications, the primary indications will be the positive effects of vascular closure device are like shorter stay, lesser complications, and contraindications like an artery more than 4 centimeters from the puncture, and arteries that are smaller, less than 5 millimeters, and also patient who already had a previous surgery in the groin.
most commonly these these vascular closure are using femoral axis angiograms. And types of vascular closure device: active and passive. Active is ProGlide and ProStar and Axera, and ProGlide is a suture based. ProStar is also suture based vascular closure device, and Star Close is based upon the retinal clipping over the femoral axis, and active is these achieve immediate hemostasis, and there are polyethylene glycol based, and that is Min-strip, and also Min-strip, and also polyethylene glycol acid is also used. And Axera is active closure wherein pre-operatively there is a flap that is raised between the artery and then once the sheath is removed, and it forms an hemostasis. And FISH is the recent advance in that is femoral entities and sheath axis hemostasis, recently developed active passive closure device. In conclusion, these closure devices achieve rapid and effective hemostasis. In Min-strip that is forming in polyethylene glycol as a glycol plug, rates of hematomas are actually higher rates of hematoma have been reported. And in conclusion, these forms
you gave a classification of active and passive. Apart from that, what is the classification present for the action closure device? Among this, which has got a higher complication rate? What are the complications of access?
Interventional procedures for UR, TR, but what are the complications? We have to treat it for like 15 minutes for the patient needs open repair of the how many percentage of cases go for thrombosis and acute ministry? Like hematoma, it seems to be sometimes high by percentage, but ischemia rate has been on the place you will decide to use particular device. You are the patient will decide, otherwise you will give manuals for this. For patient whom I do the manual compression with patient calcified arteries, and patients who are quite obese where the arteries are almost 4 centimeters from the skin, and patient who also had a previous surgery who has scar joint or hotel joint, I'll do a manual compression over using device size, all like the workflows and all the suture based sites are like 5 to 7 centimeters of this, and
This concludes our first session. Thank you, Ilan sir, Sharmila ma'am, and Nihal sir for your valuable time and input. We call the second session just on stage. Tarun sir, Sunil sir, and Shivani sir. This session's first speaker will be Dr. Abhilash Sharma, and the title is Hemodialysis Access-Induced Distal Ischemia, Recognition and Remedies.
Good afternoon, everyone. My topic for today is hemodialysis access-induced distal ischemia, the diagnosis and remedies. Creation of AV access or AV fistula is important part for the dialysis in patients with chronic kidney diseases. The most commonly used AV fistulas or accesses are radiocephalic or brachiocephalic fistulas, and distal ischemia is one of the known complications secondary to the AV access, most commonly seen in relation to brachiocephalic AV fistula. It is seen in approximately 0.1 to 8% of individuals. Usually, females are affected, and patients with known diabetes, females, and with distal atherosclerotic diseases are the one who are usually diagnosed with the same. The clinical features are during dialysis, patient can go in for pain in the fingers, or pulselessness distally, coldness or discoloration of the fingers. There are four grading. Grade 1 is no symptom at rest, but during dialysis, patient will have paresthesia. Grade 2, patient will have rest pain. Grade 3, patient will have minor tissue loss, and grade 4 will have frank tissue loss. Coming to diagnosis, one is clinical examination. During the dialysis, patient can go for either increase in heart rate or reduction in heart rate, or patient with duplex ultrasound, there can be reduced blood flow distally. CT venography can be done to look for any ischemia distally. Coming to management, we can ligate procedure called as drill, where is the distal revascularization with interval ligation. Finger capillary filtration of the finger. So we can either reposition the anastomosis distally called as Rudy, or proximalization of the fistula, where axillary artery can be taken as an influence. Distal revascularization and interval ligation. From the distal axillary or proximal brachial. 5 centimeters. Panic is one of the treatment options for the distal ischemia. What is the problem with panic? Burning, patient can they can go for loss of fistula. The fistula can get occluded. How much to ban?
वॉल्यूम कम आ रहा है.
The topic is carotid artery dissection. Carotid artery dissection is clear in the intimal layer, causing the blood to pass through between the two layers of the blood vessel.
formation and aneurysmal dilatation. Patient is most commonly idiopathic and most 20 to 40 years of age. For most commonly seen in the females of 40 years of age, and the patient may present with headache, neck pain, and expanding hematoma in the neck, and BAA, blackouts, and strokes. In stretching of the nerves causing Horner syndrome. The risk factors are the patient with migraine, uncontrolled hypertension, with the connective tissue disorders, Ehlers-Danlos syndrome, Marfan syndrome, and acute cases like chiropathic exercises like massages causes the carotid artery dissection. The patient is diagnosed in unstable patients. Doppler ultrasound is used to diagnose, while if the patient is stable, CT angiography which shows a WM sign, or the flame-shaped intraluminal narrowing, thrombus formation, pseudo-aneurysm formation, or intracranial extension. And MRI brain is also, or CT brain done to look for the intracranial extension with the SAH subarachnoid hemorrhage. Patient is medically managed with statins and antihypertensive controls. And if the patient have anticoagulation is started, as the thrombus is the most common cause of which emboli and causes the neurological symptoms. If patient is still present with the dissection, with the extension of dissection, aneurysmal extension, then endovascular stenting is done. In the endovascularly, we have to remove the thrombus, stenting, and with the angioplasty, with the stenting, if the pseudoaneurysm is present, with the embolioprotective devices. And if still the aneurysm is very large and the intracranial extension is present or complex, or any complication is attained in the endovascular procedure, in open surgery, just a ligation of intercarotid artery, the stump pressure is more than 70. Then bypasses from interpositional grafting or bypasses.
Patient is insulin resistant asymptomatic. So what do you do?
We keep the patient under regular follow-up with the doctor ultrasound. The patient kept on the anticoagulation, right? If the thrombus is swinging or not. If the thrombus is dissolving and the pseudoaneurysm tract is also dissolving, the patient will be conservatively managed. If it is more than 6 months, it's still the dissection flap is present, then I will intervene with the endovascular procedures.
Patient to have harness or partial harness in dissection. Oculosympathetic
Washing harness.
You spoke about the endovascular management. Are you aware of any specific hybrid stent which is available for this particular situation? Are you aware about the CDART stent?
Also flaring in the common carotid artery and the wide will be large and the intercarotid is the tapering in.
That's the routine for all carotid stents. They come in a tapering shape. But the CDART stent
is closed and open in the
it has a particular covering over it which allows the blood to flow through it, but it doesn't allow any thrombus to migrate through.
Uncontrolled hypertension, migraine, and connective tissue disorders, trauma.
What age group? More common in some age group.
In old age, there will be a increase in hypertension hypothesis. In connective tissue disorder, it is patient that present in younger age groups.
The patient had a stroke and the dissected vessel is completely occluded. Between intervene or management surgery.
If the patient comes earlier,
the patient has a dense stroke already, but vessel is occluded completely. What should be done?
Look for the amount of pneumonia of the vessel.
Meaning my topic is non-occlusive mesenteric ischemia, and normally it's defined as the development of mesenteric ischemia in presence of patent visceral vessels. This is commonly seen as about 15% of all mesenteric ischemias. Very commonly seen in patients who are sick, mostly seen in ICU patients who have severe low cardiac output with other comorbidities like cardiac failure, liver failure, and acute kidney injuries. They are also seen after major procedures like cardiopulmonary bypasses. Coming to the pathophysiology, usually mesenteric vessels are very resistant to developing mesenteric ischemia because of robust collateral supply. But in case of non-occlusive mesenteric ischemia, the blood supply is, because of the hemostatic mechanism of the body, the blood supply is directed to the cerebral and the other important systems, causing decreased supply to the visceral system. Coming to the signs and symptoms, usually these patients are asymptomatic and abdominal pain is absent in 25% of patients. When these patients present, they can present with abdominal distension and very non-specific symptoms. That is why we require a very high suspicion for NOMI when we see such a patient. Coming to investigation, ultrasound may show a distended bowel with no specific findings. Plain CT abdomen or contrast abdomen and such patients can show us signs of portovenous gas and distended bowel with air surrounding or signs of rupture. They are not diagnostic of NOMI. Maybe the CT may show us decreased caliber of the mesenteric vessels. The gold standard, the diagnostic point when we diagnose NOMI is presence of pruning of vessels on CT on arteriogram. Coming to the management, all these patients require stabilization first. We need to increase the blood pressure of the patient. The preferred pressures are dopamine and dobutamine. And we should have a high suspicion for development of mesenteric ischemia. In such cases, we should go ahead with laparotomy and inspect the bowel. The only surgical treatment, only option which can be done for the vessel as such is intra-arterial instillation of papaverine, which can give us some amount of vasodilatation. Patient also can be served on anticoagulation to prevent any thrombosis because of the low flow. Thank you.
Most of these patients are intubated on sepsis patients, so we have to suspect NOMI. So apart from distension, what else you can? How we suspect a NOMI?
So we can look for the inflammatory markers, ESRC, all these markers will be indicated, and
specifically what levels increase with the bowel ischemia.
LDH.
Okay, and ABG what is
Value metabolic acidosis.
Which causes metabolic?
The lactic acid.
Significant lactic acidosis in there.
Who will approach the bowel in such a patient with NOMI?
Sir, we will do a damage control surgery here. We will not look for a curative resection of the bowel if the bowel is gangrenous. If the bowel is not, what we will do is whichever bowel is frankly gangrene, I will dissect it and keep it as a stoma and reassess. We do a relook laparoscopy after 24 to 48 hours.
The threshold for resection will be lower than the usual bowel ischemia.
You spoke about the endovascular installation of Pelvic.
Yes.
And any other drug which can be used?
Sorry. Dopamine usually helps in. We have to basically stop the vasoconstriction. Papaver is the only drug proven to help in such cases. Adrenaline and leptin and norepinephrine are the.
Next speaker is Dr. Rohit Kumar. His topic is endolic subperineal classification and management.
Good afternoon, sir. Endolic is the persistent filling of the sac after the EVAR. There are usually 20 to 30% of the cases after the EVAR, there will be an endolic. There are basically 5 types of endolic. Diagnosis of the endolic is by primary CT angio. And contrast enhanced ultrasound also helps for diagnosis of type 3 endolic. And there are 5 types of endolic. Type 1 endolic. The endolic is from the proximal or distal 1A or 1B. Proximal is the 1A and distal leak is the 1B. And type 2 endolic is from the retrograde flow from the collateral or the lumbar artery or the IMA. And type 3 endolic is due to modular defect in the graft or fabric tear. And type 4 endolic is due to the graft porosity, and type 5 is diagnosis of exclusion when other causes of endoleak is not found. And treatment coming through the type 1 endoleak for 1A endoleak, usually plastic can be done over the proximal end. If it still persists, then real extension of the graft can be done. And recent studies, you can use endoclips also and the endoscopy. And 1B, you can distal extension of the graft or plastic can be done. And type 2 endoleak, usually from the collateral, it usually resolves. If it doesn't resolve, then laparoscopic ligation of the lumbar or to the collaterals to the SMA, we can intervene and embolize the artery. And type 3 endoleak, it is due to the graft tear or graft tear. Usually realigning of the graft can be done. And this is the most common endoleak, considers immediately to be intervened. And type 4 endoleak, graft porosity, it can be left alone, which is regressed by itself. And type 5 endoleak, either
theoretically, they have enumerated all types of endoleak. So chimney procedure is very common these days, especially we have Juxtarenal aneurysm. So how do we minimize the chance of type 1A endoleak when we are doing a chimney procedure?
While planning only is request type to plan to challenge approximation of the graft.
Are you aware of something in gutter plates or number of chimneys? Number of chimneys does it affect the possibility of increase in endoleak? Number of chimneys definitely weight of body. What is the length of the graft? Do that also matter? Because the chimney length should be more problem to the graft. We spoke about the endovascular technique of taking care of type 2 endoleak, especially if it's happening from the lumbar. And sometimes it can happen to the inferior artery as well. So in case you have to do the angioembolization of these vessels, how do we manage them endovascularly?
Endovascular, so the SMA, the artery of stoma,
And the reason with the demonstration of type 3 is divided to A.
3A is due to the scaffolding of the graft with the cancer, and 3B is the graft tape.
The number of aneurysms will increase significantly. So a lot of people try to percutaneously directly access the SAT, and through the SAT they try to enter the vessels and enter.
Next is Dr. Rajkumar. Subsequent Nutcracker syndrome, going to attend.
Good afternoon, sir. My topic is Nutcracker syndrome. Nutcracker syndrome is a compression of the left brain between the abdominal aorta and SMA. It is usually SMA, the reduced angle, aorta is reduced to 35 degrees. Types may be anterior, and because compression between aorta and SMA, the posterior Nutcracker syndrome is aorta and the vertebral body. Atypical Nutcracker syndrome arises when there is a circumaortic left renal vein or due to extensive compression of the left renal vein. Investigation symptoms, patient usually presents with a persistent microscopic or gross hematuria, left flank pain, and orthostatic proteinuria, and severe weight loss due to attributed to severe anemia patient. Investigation start with evolving the investigation usually evolves around reflex ultrasound, assessing the systolic velocity of the left renal vein more than 200 centimeters per second, and the real-time imaging to assess the MRI to assess the iotometric narrowing, and diameter of the left renal vein, proximal and distal to the compression. And management starts indication to management is severe hematuria to contributing anemia, flank pain, and orthostatic proteinuria. When to intervene this, initially patient, in case of children, it can be tried to conservative management due to the
increase retroperitoneal fat deposition, which increase the isometric pattern, which usually central to the result. Conservative canal management can be followed after a period of 18 months in case of children, and adults 26 months. Surgery is planned. Open surgery is the best preferred because most of the patients are doing. Surgery types are left renal vein transposition, either reimplanting into the IVC directly or using a interposition subcutaneous vein graft or femoral vein graft or a gonadal vein transposition. In case of posterior NCS, transposition is little difficult. We got to may induce the vein and go for the subcutaneous vein graft. Endovascular management is usually not preferred because it has complications like stent migration and stent rotation. If endovascular is preferred, we can prefer for hybrid method, both open and stent placement. Hybrid starts with elaborate transposition.
Any scrotal pathology could be a manifestation of Acute syndrome?
Due to Canada reflex, so when you decide upon LRV transposition versus Vascular transposition, typically in mobilization we have seen a gonadal vein diameter to be at least 70% the diameter of the left renal vein. Then we can go for the transposition.
What is a preferred conduit for replacing the vein when you do subcutaneous vein from the vein?
Subcutaneous vein diameter is not adequate, we can go for SFP.
What is the role of graft?
If the distal is fibrotic and atrophic, if you have disease to heart, then we can turn the disease to heart and use a subcutaneous vein.
Prosthetic graft. Any role?
But all you have to use water in the muscle and the PPF.
What is the investigation of chance to diagnose of the all the modalities? What would you prefer actually?
MRI.
We spoke about angle. This investigation you can create with ultrasound, doctor, or
what about pressure difference, which is how much pressure difference should be there between LR and LVC to say the significant? At least 3
thank you.
Next is the topical cephalic arch stenosis or occlusion, pitfalls of endovascular management. Cephalic arch stenosis or occlusion, pitfalls of endovascular management.
Good afternoon, everyone. Cephalic arch stenosis, coming to the anatomy, the cephalic arch joins the axillary vein. At that site, there is an increase in angulation. There are anatomical constraints like the availability of clavipectoral fascia and deltopectoral glue, and high hemodynamic stress, which results in endothelial damage followed by stenosis at the cephalic arch. So here the endovascular pitfalls in this treatment of these patients are, with the usage of percutaneous transluminal angioplasty, the primary patency at 6 terms is only 40%. And it is termed that the studies have shown that they require re-intervention approximately 2.7 times per year and the high risk of restenosis. The second form of treatment, endovascular treatment in these patients can be stenting. With the usage of bare metal stenting, the initial results have proven to be increased patency, but the long-term patency drops to about 20%. The usage of stent grafts in these cephalic arch stenosis have proven a short-term primary patency rates of about 60%, wherein these can be preferred at the initial statement, but they do not address the anatomical constraints like clavipectoral and deltipectoral patients. Then the fourth thing which can be addressed in these patients are usage of drug-coated balloons, wherein there is a local delivery of drug into these lesions. The studies have shown that it is almost equivalent to the stent, cover stent, wherein coming to the conclusion, with the usage of different types of treatment, the stent grafts provide to be a reasonable option of treatment in septic cord stenosis. If endovascular treatment fails, the surgical option should be considered, like cephalic vein transposition, cephalic vein turn down.
Are you aware of any specific stent graft which has been specially made for this particular pathology? Covered stent or a self-expanding platform, and it comes in a flare shape. That is the ideal for non-canal vascular. The Supera stent, that also is a very ideal stent for that particular situation, which has shown a good patency. Only downside is sometimes the diameter available in that stent is only 7.5.
What other hardware can you use in treating the patient according to stents like packing balloons or roll packing balloons?
In chronic cirrhosis, we find you can use cutting button techniques
What is the indication of surgery? When you say endovascular has failed and now we go to surgery, what is the rate? Any time frame stable within this many months, say number of failures per year?
It's shown that the 0.7 failures per year, the increased reintervention or instant stenosis.
And how do you clinically evaluate this patient? That probably you suspect that probably this patient is developing a cephalic arteriostomy.
With the creation of the patient is developing the shoulder
high venous pressure and loss of thrill, which start happening.
Endothermal heat-induced thrombosis and endovenous fluid-induced thrombosis for the recipient blood flow.
My topic is the endovenous heat-induced thrombosis and endovenous fluid-induced thrombosis. Usually, heat and heat occurs in 1 to 7% of patients. Coming to the classification, heat thrombosis but not involved in the deep vein. Type 1 and type 2 thrombus less than 50 centimeters of deep vein. Thrombus more than 50% of the deep vein. Thrombus completely occluded. Coming to the Egypt, the classification of thrombus is less than 25%, 25 to 50%, 50 to 75%, more than 75% to 100%. Risk factors for the heat and Egypt are pre-existing thrombophilia, history of DVT, long segment vein radiation ablation, and larger diameter vein ablation, and use of high energy setting procedure. Prevention is we can treat with appropriate techniques like surveillance for the type 1, surveillance, no treatment and no surveillance required for type 1, surveillance only enough for the type 2, no treatment. Type 3, appropriate anticoagulation. Type 4 is treatment with the DVD thrombosis. The prevention is the better. We can prevent the heat and heat by ablation away from the SFA junction and proper assessment and proper risk satisfaction, and compression bandage, we can prevent this heating. And coming to the progress is if you take appropriate measures and prevention measures, we can the management, the progress of heat and heat are good. So, limb elevation and with rub bandage will prevent the heat and heat.
Oh, okay. Is there any difference in EHIT versus like Arnold versus laser versus Supera versus glue? Any difference in EHIT when compared with modalities like radio frequency versus laser versus like all the modalities are available? Is EHIT more in some modality?
We can ablate from base of the.
No, the question is EHIT more in some modality when you compare to other modality? Is the EHIT more in some modality?
Yes, sir.
Are you aware of anything?
Laser.
What measures you can take to avoid EHIT?
Pre-operative assessment and risk assessment and avoid of the high energy and ablation from the away from the junction, compression bandage and limb.
Any role of thromboprophylaxis, routine thromboprophylaxis in all patients who undergo endovenous thermal ablation?
No need, sir, but in these patients we prophylactic anti-coagulation.
Sorry?
Prophylactically anti-coagulation in some patients.
There is no evidence to prove that from this will prevent EHIT, but we do routinely, but the evidence is not that you are in all patients get that from not present. What is the drug? What medicine you give to diagnose EHIT?
LMW.
Or any routine AVAX?
Apixaban.
And how early do you suspect it to develop? Suppose you have done a procedure, index procedure today, so like 2 days, 3 days, 4 days, within 24 hours.
Immediately after surgery, we will look after for any DVD. The immediate next post-operative 1 day, 1 vision after 12 hours. Thank you. Thank you.
Next is Dr. R. Mahesh. His topic is arterial thoracic outlet syndrome, modern approach.
Good afternoon, everyone. I am Dr. Mahesh from Nizam Institute of Medical Sciences. My topic is ATAR. This is the arterial thoracic outlet syndrome, which is a compression of subclavian artery between the cervical rib and subclavian anterior skeletal muscle. These patients will have. These are more in female with the 4th decade of life. They will present with the right upper limb claudication pain without distal ischemia. Coming to the ATAS, only 1% of total TAS will have arterial involvement. And coming to the classification, share classification is the shape classification divides into stage 0 to 4. Stage 0 is no symptoms with the ATAS. Stage 1 is mild claudication symptoms with the slight post-stenotic dilatation of the subclavian artery. And stage 2 is neural involvement in the form of thrombus or distal thrombus. This is the stage 2. Stage 3 is complete or near total occlusion with the distal embolization with the ischemia. Coming to the diagnosis, clinically we can do Roos test, elevated arm stress test. We can diagnose. Coming to the investigations, CT angio upper limbs is the investigation of choice. Or else we can do MR angio with the two views, one with elevated
to be surgical options for treating thoracic outlet arterial compression? What approach is the best approach, and what are the important structures which can be injured while operating on that?
The supraclavicular approach is the best approach. And coming to the structure, we'll encounter the phrenic nerve towards the medial of anterior sinus muscle. And below that, we'll have long thoracic nerve of dead. And we measure the brachial plexus in the.
Any chance of causing pneumothorax? And any precaution, or like if it's being done in a hybrid lab, it's fine. Otherwise, you want to get any investigation done post procedure for these patients. A simple chest X-ray for any reason. We'll manage post-op type. Which side is more common?
There is left side more common.
Let the injury happen.
If at all detection the intraoperative only, we will like it.
Post-op brain is having continuous.
We have to
This
open
amount
like
is less.
less means we manage under
Based on how much is coming. So excess amount, liters of high test.
Then we have to open it like it. How we identify this? Sometimes methylene group.
Then we will inject methylene group.
What are the incidence and aneurysmal dilatation of the artery? Acute.
Thank you. Next is Dr. Vijay Kumar. His topic is Basel 2 and 3 trials. What has changed?
Good afternoon. My topic for today is the Basel 2 and Basel 3 trials. What has changed? So basically, Basel 2 trial is an open phase B trial, pragmatic trial, multi-center trial, which involves compared to two different surgical approaches, that is open bypass surgery versus breast endovascular surgery in intrapopliteal revascularization. So basically, the aim of Basel 2 is to look for the primary outcome, the amputation-free survival, and the secondary outcome for the male and the waist population. In this, the RCT trial, divided the patient into two groups. One group for the open bypass surgery for intrainguinal and breast endovascular procedure. It's this the aim, and finally the Basel 2 concluded the breast endovascular procedure is the best outcome with male outcome in compared to the open bypass. The hazard ratio was low in the breast endovascular. Basically, the Basel 2 ends up finally with breast endovascular approach is the superior when compared to the brain bypass for an intrainguinal popliteal revascularization. With compared to the MACE primary outcome and the secondary outcome, this is. But the endovascular or the intrainguinal approach, the morbidity and mortality was also high in intrainguinal cohort 1. But in Basel 3, it's a recently published trial. They're comparing the drug-eluting balloons and drug-eluting stent, which has 3 cohorts. First cohort has only the POBA, it was 20 bare metal setting. Second, with DCB, this was 20 with artificial. And the third is directly drug-eluting stents. Again, this Basel 3 also suggested that no significant difference in the primary outcome with use of this POBA. However, the patency and was high with compared to the.
Thank you. Basel 1, Basel 2, and Basel 3 also, all the results out. How can they affect your clinical practice? Like if you have a patient with alpha-popliteal disease, what would be your first choice to intervene with endovascular, with just a balloon, or the stent, or do the bypass?
Definitely for intrapopliteal, no role of stent will be. Our approach will be the first is the endovascular approach for intrapopliteal. If the probably endovascular stroke is not possible, then we'll for vein bypass. What was the criticism for Vsi 2? Vsi 2 and Vsi like almost same. Vsi 2 was the major criticism.
So they include the suprainguinal revascularization also. Aortic occlusion also has included. That was the major difference in the Vsi 1. They didn't include the optimal occlusion. This also they consider to include this thing. Here the surgeon decides which patient, that was the bias where the best endovascular approach and the best pain type of approach, the surgeon decides. Also that was the bias.
Only surgeons were there, operators were not operators. Basically.
What is the difference in outcome measures when you consider Basin 2 and Basin 3? What outcomes are looked into? And what is the difference in the outcome? Means what outcomes are looked into?
Major adverse events for primary outcome in the both the Basin 2 and the
Basin 2, they looked at patency of the procedure, but Basin 3 looked at functional outcome of the procedure. So this is the difference basically Basin 3 and 2.
Basin 3 was immediately stopped. What was the reason?
So the drug was developed and the development, the concept of the mortality was
Because of what? What specific side effect was quoted, but it was not included. MI was initially because of
Next is Dr. Vinodini Palaniswamy. Her topic is Heparin-induced thrombocytopenia, diagnosis and action.
Heparin-induced thrombocytopenia is the disorder of immunoglobulin and G antibody formed against heparin PF4 complexes. It can be seen around 5%. The heparin PF4 complex is the antibodies joined produce Fc domain, which can bind with platelets, monocyte macrophages, and it can progress the tissue pattern, can increase the thrombotic state. So it is most commonly seen in females, autoimmune disorder, and surgical patient. It can present with DVT or pulmonary embolism. 4:1 ratio venous system is affected, then there is system of thrombosis. The diagnosis by there is a 50%, more than 50% reduction in the platelet count within 5 to 14 days of exposure of the heparin, and alternate diagnoses are excluded, and patients are presented with there will be no petechial hemorrhages or bleeding, and heparin injection site are mainly presented with ecchymosis. The diagnostic investigation is immunological assays, immunosorbent assay, the confirmation test with serotonin release assay. These patients should be evaluated for DVT in the system, and also all sites of heparin should be stopped, and heparin flush also should be stopped. Alternative anticoagulation should be started, and exactly the dual reading P7, rivaroxaban, fondaparinux can be given, and the platelet count should be normalized. Until then, we should not start warfarin, and alternate within 5 to 10 days we have to look for DVT and pulmonary embolism.
Thank you. We have more venous thrombosis and desperate arterial thrombosis in patients.
Venous thrombosis is more common.
And you said we have to have alternate anticoagulation. So patients won't get sufficient needs, any procedure of needs and heparin. So what is the alternate for any
For
procedure?
parental anticoagulation, we have to start fondaparinux.
No, it is not therapeutic. You are doing some procedure, intraoperative aneurysm or bypass. You always give heparin before planting, right? This patient, what do you do? Contact illness, no work, sir, for post or therapeutic anticoagulation. Liver is intravenous infusion. 4 T's of the treatment.
Time of onset, within 5 to 14 days of heparin exposure, and there is more than 40% of reduction of the platelets from ischemia. Alternative diagnosis of thrombocytopenia should be excluded, and thrombosis should be diagnosed. Type 1 and type 2. Type 1.
Thank you. Your time is up. Thank you.
Thank you to the scholars and the judges. Move on to the next section, section 3. Dr. Manvindu Jha, Dr. Ashish, and Dr. Mahmood. The scholars will be Dr. Neelam and Dr. Abhishek. Waiting for Dr. Pool to finish the call and then we'll start the session.
Okay, let's start with the first. It's Dr. Anurag with the topic of sclerotherapy for venous and lymphatic malformations, agents, techniques, and potential complications.
Good afternoon, everyone. So, sclerotherapy is basically it's a minimally invasive technique we can use particularly in cases of low flow venous malformations or lymphatic malformations, particularly macrocystic or microcystic. Now, when we talk about different agents for venous malformations, we have something called as sodium tetradecyl sulfate or even polydecanol. Both of them being detergent agents, what they do? They are basically responsible for causing endothelial damage at local site, which in turn stimulates the process of thrombosis. Now, there are no generalized symptom complications associated. However, local symptoms can be associated, such as pigmentation or ulceration at local site. There are other agents such as alcohol. Now, what is alcohol? Though a very potent agent, has higher side effects. Though its patency is almost 100% in showing results, but it can cause arrhythmia as well as it has a risk of pulmonary hypertension associated with it as well. Now, other agents that are commonly associated can be used in cases of lymphatic malformations can be bleomycin. Bleomycin being a chemotactic agent will cause local site denaturation, fibrosis, eventually will lead to thrombus formation. Now, the technique is basically for both the cases, the technique is basically same. Under ultrasound guidance, we'll put a catheter inside. We'll put a contrast agent to look for the extent of the malformation. Now we can either aspirate. In cases of venous malformation, we'll directly insert the sclerosing agent, give compression for around 30 to 40 seconds. However, in cases of lymphatic malformation, we'll allow it to sustain there for a period of around 30 to 60 minutes, depending upon the variation of the lymphatic malformation. Post this, we'll give a local site compression elevation. Thank you.
What is the side effect of bleomycin for which we have to be safe?
Well, regarding the cases generated contraindicated for this cardiac.
I think that is the lab for which the dose has to be very specific in bleomycin. Pulmonary fibrosis. You said you will inject, you will place a catheter. And then you said catheter.
You cannot place a catheter when you are doing a percutaneous injection.
Micropuncture needle, we can insert, we wait for the backflow. Either we insert the contrast needle on the basis of the backflow, we can go ahead and do a.
What is the most important thing when you inject your contrast and see it on the screen?
Look for any collateral or any
Point which is important for your decision making whether you proceed with the sclerotherapy or not. You will inject the sclerosant or not.
So you can arterial communication.
Any other thing? Something related to if you are going to continue. You have to see the deep communication. If it is going into the deep the contrast is going into the what is the method to prevent that? If you see deep veins, but you have to treat it, it is very symptomatic. Anything that can prevent? What kind of compression?
Doctor, under using compression of junction.
Anything else? Simple? If you don't have a doctor, one of your assistants.
Thank you. Next, we have Dr. Karupasivan with the topic popliteal artery entrapment syndrome.
Public regarding entrapment was described by Anderson Stewart and his students. With developmental anomaly in which the iliofemoral system and the axial artery are poorly developed. The popliteal artery, the deep part of the popliteal artery is usually involved, but in popliteal artery entrapment syndrome, the deep part may remain persistent and subjected to small patients may be developing gastrocnemius. Usually, gastrocnemius is attached to the tibia, but the development occurs, it is it migrates cranially to the femoral condyles. Popliteal artery entrapment syndrome may present with claudication in young males, the mean age of 32 years. It is bilaterality in about 30% of individuals. It has atypical claudication in which the pain gets relieved by vigorous exercise and aggravated with standing or walking. Related with CT angiogram or DSA, but the test of choice is MRI, in which the abdominal muscle can be found. Heidelberg classification classifies popliteal artery into 6 types. First one is the abdominally mediated elevated muscle. Second one is the abdominally attached median elevated popliteal artery in the first type. Second one is the abdominally attached medial head. Third one is the fibrous band, which is dividing the popliteal artery. Fourth one is the axial artery persisting at the distal part of the artery. Fifth one is both artery and vein. Any clinical test you can do to confirm popliteal artery entrapment? The what? Bedside angiogram. Passive dot reduction and active blank obstruction, disappearance of the popliteal pulse. Usually the symptoms are aggravated by exercise, right? Relieved by exercise. Relieved. It is aggravated or it is released by exercise. Symptoms. My question is very simple. Patient performs a physical activity, symptoms will worsen or symptoms will relieve. Usually in claudication, patient tends to get more
symptoms due to lack of blood supply. Where the pathology is due to abnormal muscle position or deviation of the popliteal artery, due to enhancement of the contraction of the muscles. Some patients experience breast symptoms.
What is the usual patient profile?
Young age group, men with middle age, 32 years. When you are active in
Which group?
third decade of age,
Not below 30. Any role of endovascular management in the treatment in the management of popliteal trap?
asymptomatic,
You want to go for a surgical approach or you can try endovascular?
surgical approach to use the
Thank you.
Thank you. Next we have Dr. Abhishek with the topic Reynolds disease, diagnostic pearls and management.
Good afternoon, sir. I am presenting on Reynolds disease. Reynolds disease is a vasospastic disorder characterized by episodic vasoconstriction of the distal vessels. Patients usually present with episodic episodes of numbness, and it can be broadly classified as primary and secondary Reynolds. Primary is idiopathic, principally occurring between 15 to 30 years of age, whereas secondary is mostly due to other generalized autoimmune conditions like SLE, scleroderma, or systemic sclerosis is the most common. Classically, they present with three phases. First is pallor phase, followed by cyanosis phase. Third is Ruber. Pallor is due to vasoconstriction. There will be decreased blood flow, which causes whitening, and then secondary is cyanosis due to blood collection, and third is due to vasodilatation. There will be Ruber phase. And coming to clinical features, typically they are present with episodes of these three phases. And investigations, primary Raynaud's is mainly the diagnosis of the exclusion. First, we have to exclude the secondary causes of Raynaud's, which include ESR CRP, which can be elevated in secondary Raynaud's, or anti-dsDNA or anti-dsDNA, anti-FCL70, other immunomodulator, which can be evaluated. And coming to management, first is we should avoid exposure to the triggers like cold exposure and periphery exposure to other trigger factors. And medical management include calcium channel blockers, alpha blockers, or topical nitrates or SSRIs are used. And in case of advanced diseases, we can go for botulinum toxin injection, or we can go for cervical sympathectomy also, sir. And in case of secondary gangrene, then we may do digital amputation and debridement, sir. Thank you.
Any role of antiplatelets?
No, sir. It is mostly due to vasoconstriction, sir. Only if we have to rule out other secondary causes. If the patient presents with gangrene, we may start on antiplatelets, but generally only calcium channel blockers and alpha blockers.
So first instance, when there is no gangrene, if the patient has cyanosis, sometimes rest pain, you won't prescribe antiplatelet.
No, as a prophylactic measure, I can use, but not the mainstay treatment. What's the role of stent management? Avoidance of exposure to these external stress factors like exposure to cold or exposure to vibration, and whatever triggers for this patient in extremis we can avoid. It will be young, around 15 to 30 years of age in females, whereas secondary is mostly older. For either, and the SSRIs can be given to for emotional stress.
How frequently do you do a digital amputation in patients with Raynaud's?
Mostly rare.
Last question. What is the
Raynaud's phenomena and Raynaud's disease, both are same thing or different?
Raynaud's phenomenon is the typical occurrence of this characteristic pre-table. Raynaud's disease includes of
Thank you. Next is Dr. Rashmi with the topic Klippel-Trenaunay syndrome, what the vascular surgeon should know. Good afternoon. My topic is Klippel-Trenaunay syndrome, what a vascular surgeon should know. Klippel-Trenaunay syndrome is a rare congenital syndrome with a triad of capillary malformations, lymphatic malformations, and venous malformations along with limb hypertrophy. So how a vascular surgeon is related to it because of involvement of capillaries, veins, and lymphatic. Capillaries involvement is shown as port wine spaces, and in case of veins, there will be varicose veins, and even the deep veins can be involved in patients. In case of lymphatic malformations, has to be ruled out in some patients. How do you know if the patient is having Klippel-Trenaunay or not? It is mostly sporadic. It is seen in 1 to 30,000 births. So it is mutation in PIK3CA gene. Clinically, you have to evaluate the patient for varicose veins, any capillaries are involved or not, lymphovenous malformations, and limb girth measurements has to be done. Duplex scan to rule out varicose veins, and MRIs to see for any lymphatic involvement. So, other features that can be seen are chronic venous hypertension, cellulitis, and repeated infections for the patient. So, how do you treat them? We should try to avoid surgery as much as possible because recurrence can be there and wounds cannot be healed following surgery. So, compression therapy and antibiotics for such patients will be the first line of management in such cases. When limb hypertrophy and limb is involved, a combined approach with orthopedicians should be taken and plastic surgeons should be taken for correction of the limb deformity.
What is the most common venous anomaly?
Marginal vein of Cervelli.
Which one? Which side? Is medial lateral? Middle? So what is the difference between a marginal vein and a normal vein? Something difficult.
There are no valves. The valves are absent in case of marginal vein.
Anything else related to wall of the vein?
Then so there will be repeated bleeding in the episode.
So why it is thin? What is the problem during development that has led to that vein? It is an embryonic vein. Okay. Any role of endovenous laser in treatment of marginal vein? First of all, it is not medial, it is a lateral. Then the role of laser treatment or endovenous ablation. What is the most important thing you look for before doing the laser ablation? Apart from thrombosis? What other anomalies can occur in the patient? There may be a complete absence of the patient. Then we cannot update the
What are any indications for intervention in Klippel syndrome? What are the indications of intervention? I want to ask what are the complications of Klippel syndrome?
Thank you. Next question is Dr. Prashant Jain. His topic is drug-eluting balloons and stents. Current data for use in terms of therapy.
Good evening, everyone. I'm Dr. Prashant from Supera Hospital. Drug-eluting stents are a scaffold which has a metallic stent and an polymer coating and an antiproliferative drug. Based on this, there are different generations. First generation stent was sirolimus and paclitaxel eluting. Then second came the everolimus and zabavolimus, and third generation were bioabsorbable drug-eluting stents, in which they had lactic acid polymer or magnesium, and in that scenario, after 6 months, most of the stent material gets bioabsorbed, and the vessel lumen remains patent. Then coming to drug-coated balloons, there are the drug-coated balloons have a polymer coating with a drug over it, which one-time application into the vessel, and there is nothing is left behind in the vessel. This is the advantage that they give over the drug-eluting stents. And then there are one disadvantage with drug-eluting stents is the need for dual antiplatelet therapy, which is not needed in the drug-coated balloons. And multiple trials have been done for both, like Silver PTX trial or Siloco or the Stripes trial for the drug-eluting stent, which shows mixed results for the patency of the vessel. And Impact trial has been there for drug-coated balloons. Then the Basic 3 trial also came, which compared drug-coated balloons and DES with POPA, showing no long-term efficacy in the or change in the outcomes with the plain POPA.
What are the contraindications of using a drug-coated balloon?
If the patient is having known allergy to the blood,
In your practical experience, in your daily practice, what is the most common case scenario where you plan for a DEB before starting your case?
So DEB is we can use for the instant restenosis cases, or if the after atherectomy we can for intragenicular lesions, intrapopliteal lesions where stenting is usually contraindicated. We can use a drug-coated balloon.
Do you directly inflate a drug-coated balloon or you do something else?
So first pre-dilatation of the vessel and preparation, and then we use a drug-coated balloon.
So pre-dilatation with what size balloon?
So usually 1:1.
If your SFA is 6 millimeter, what size of pre-dilatation and what size of DEB will you use?
So 1:1.
Pre-dilatation up to 1:1.
Yes.
So you do a dilatation with a 6 mm balloon, 6 mm vessel, and you see a good endovascular result. Still you do a DCB.
Sir, if there is a significant recall for the stenosis, then we can do the DCB. Otherwise, there is no application.
Thank you. Next gentleman is Dr. May-Thurner. His topic is Takayasu arthritis, a vascular surgeon's perspective.
Good afternoon, sir. My topic is Takayasu arthritis. Takayasu arthritis is named after the Japanese ophthalmologist Hideo Takayasu. It is characterized by autoimmune arthritis affecting all the layers of the large vessels, most commonly aorta, circulatory artery. Patients in the pathogenesis are genetic predisposition. Cellular DWP2 antigen is responsible for this most common swing pattern for Takayasu arthritis, and which is more common in female. So this level of estrogen level is bound to be important risk factor for Takayasu arthritis.
And also patient having mycobacterium tuberculosis infection are more prone for arteritis. The pathogen, the histology features will be pan-arteritis involving all the layers of the vessel, intima, adventitia, and media. Clinical symptoms are first phase, second phase, and third phase. First phase, patients have vague symptoms like pain, swelling, myalgia, loss of weight. In phase 2, patients will have tenderness along the vessels, carylinia. In third phase is called the burnt-out phase. The patient will present to us with aneurysm formation and other complications. The investigation we do for arteritis, blood investigations, elevated ESRCRP inflammatory markers, interleukin 6. All inflammatory markers should be elevated in case of arteritis. Other investigation we do for CT angiogram to look for aorta and MRI. In order to see the disease activity, we can do PET scan also to see the disease activity. Some diagnostic criteria are given for arteritis. One of the criteria is American Society of Rheumatology. It depends upon 6 major criteria: the age of onset before 40 years, and distal claudication pain, and diminished brachial pulses, and pressure difference in upper extremity is more than 10 mm mercury, and associated with supplying growing on either side. In order to see the disease activity, PET scan we can do PET scan. The patient having symptoms related to claudication in our upper limb can do for CT angio, pan aortogram to look for endovascular hypertension and aneurysm formation, and to CT angio. Once it is diagnosed like arteritis, what is the main line of treatment? Is it medical or surgical? The first line of treatment is medical management. We will start on topical steroids, fitness alone. If the patient is having remission, we will add immunosuppressants like remember and cyclophosphamide. If the patient is refractory to this medical treatment, we go for a targeted therapy and interleukin. The role of antiplatelets and anticoagulation in autoimmune vasculitis. What are the indications of open surgical intervention in cardiology? So, patient present with complications like aneurysm and occlusions, they will prefer open bypass. When will you do an endovascular burst? So, endovascular is preferably for renal vascular hypertension. So, patients suffering from renal or stenosis, we will go with renal angioplasty and stent. In other cases, open surgery is best. So, like, if there is a situation like there was a cardiac arteritis and it led to the occlusion of the vessel. Now the PET-CT is negative and the disease is in the remission phase. Now the picture is of a peripheral artery disease. In this situation, can be intervened or not? The patient is suffering from peripheral artery. In such cases, you should intervene either endovascular or open and vascular. Thank you.
Next is Dr. Ilayaraja with the topic venous stents, features and selection criteria.
Venous stents are basically used in renal chronic venous insufficiency and post in case of PTS. Usually the venous stents has a good quality because it should have a longer length, it should have a rust resistant, migration resistant, it has a good opacity, and it should not have a minimal foreshortening of the graft, as well as the graft should have a minimum length of length should be more than compared arterial component. So IVS is the most important thing. The IVS criteria, usually the vein, when you use a vein stent, it should be more than 50% of the volume reduction should be there, and as well as in the common area vein, the cross section area will be more than 200 millimeter, and so stent should be more than 16 millimeter size. In XL area, it should be more than 14 millimeter size, which is needed. So there are various studies. Commonly, we are using venous stents like Venova, sinus obliques, and grade, wall stent. These are the fewer venous stents. So, using a venous stent, the complications of venous stents are stent migration, restenosis, and sometimes thrombosis will happen. So, before doing a venous stent, IVUS studies is the best thing to do to choose the venous stents. So, better to avoid venous stenting in the common femoral veins.
What are the types of venous stents?
Actually, open. Usually, we use venous which is open filtered.
What is the basic difference between an arterial stent and a venous stent?
Self-expanding metallic stent we are using. Usually,
What is the difference between an arterial stent and a venous stent? Not tailor-made stent for venous circulation.
you should have a more radial force. You should have a crash free, less mild.
Any difference in design? Why do you specifically call it as a venous stent? Why do you call this as an arterial stent? There has to be no difference. Okay, you talk so much about IVUS. Suppose you don't have IVUS in your center, then how will you have decision making for venous stent? So what are the points you have to know clinically on your angiographic image, depending on the symptoms of the patient? So how will you make a decision? First, let me clinical judgment.
So when you are doing a DSA, then the venous reflex.
Clinical judgment means patient comes to you in your OPD. How symptomatic?
Those patients will have ulcer, those patients will have a chronic venous edema or long-standing venous edema.
Okay. And angiographic findings?
It should be a narrowing of the venous segment.
So you do elections, you can see that narrowing.
Reflex of the.
Any other test if you don't have an IVUS? Something else? Cardiac complex would give you so much difference. Anything? Balloon inflation?
Next is Dr. Rohit Devi with the topic Glucose syndrome, diagnostic tools and management.
Good afternoon. I will take the glucose syndrome. In glucose syndrome, they particularly present with cyanotic exchanges with favorable distal pulses. So they can also present with fatty distillation of the exchanges over the field and lower stool. And they can progress into fissure and ulceration and eventually gangrene of the throat. Whenever someone presents with glucose syndrome, after a simple diagnosis, we should rule out the faster with glucose syndrome. Most commonly, it is due to cholesterol crystal embolization fraudulently, or it can be from cardiac source or arterial embolization. So to rule out this, we will do imaging in forms of CT angiography or TEE to rule out this. If there is a definite source of embolization, particular clot in the aorta or in the distal arteries, and we should offer them intervention such as constant placement or to stent placement for the heart. And for the dose, it is very symptomatic management, with pain reduction and
will see in the severity of the exchanges will be cholesterol system there. And prevention strategies, we should look at using high-dose statins to which has neutropenic effect over the respiratory tract.
What can be a differential diagnosis of use of the
Can be because of vascular should be overload. And we have to use it and there is nothing under the track.
Can it be aneurysm in the proximity from there? It can go and enter the right tract.
It can be in the which is the most common aneurysm?
How will you manage the patient? Immediate treatment of Bluetooth syndrome? Symptomatic management of the patient. What type of analysis? Opioid, non-opioid? Anything else? Any pain and patient, normally Bluetooth syndrome patients have acute pain in the ward. Analgesics, statins, anything else?
Any role of putting in a bare metal skin? You said covered skins. Why not bare metal skin? There is a 3 to 4 times cost difference in a covered skin. What type of bare metal skin you should put?
Thank you. Next up, we have Dr. Bhattacharya with the topic statins in vascular surgery beyond lipid load.
Good afternoon, everybody. The topic is the role of statins in vascular surgery beyond the lipid lowering effects. So, other than the effects of reducing the lipids in the body, the statins also has an antioxidant effect. So, reducing the free radicals in the blood circulation. And the studies have shown that it will increase the stability of the endothelium, thereby reducing the thrombus formation and the thrombogenicity of the endothelium. And it also has got an anti-proliferative effect. So it reduces the cell proliferation at the level of intima, and it also has got an immunomodulatory effect. So the effects, so it counteracts some of the inflammatory actions into the autoimmune diseases and vasculitis and as well as TO settings. And so these are the some of the effects of lipid lowering agents and statins, and some of the studies which are shown the other effects are Jupiter study and the Cardiovascular study, Forest study, and so these are some of the studies which have shown that the these effects of the statins and their uses in the high dose of statins have been used in the claudican patients along with our philosophical medications along with ecosprin. So shown to have beneficial effect, although not fully proven. And as well as in the post-operative cases, in especially patients who have undergone stuntings and angioplasties, so high doses of statins have been shown to be beneficial, particularly in patients. The studies have mainly focused on the cardiovascular diseases, but they can be extrapolated even to the peripheral arterial diseases.
What are the common side effects of statins? high dose statins, what are the indications? And what conditions will give high dose statins?
Triglyceride levels of more than 250, 300, and LDL levels of more than 250, and patient with unstable plaques, and patients with lipid-rich plaques, and then vulnerable plaques in the carotid, and patients undergoing patients on conservative management for a non-reconstructible disease, and patients undergoing stenting. So these are some of the clinical indications where we use high dose statins.
Any evidence you can tell where it has been shown that statins might not be required in cases of POD? They have no role in POD as far as which is concerned.
I'm not sure.
Thank you. Our next guest is Dr. Sinha with the topic Ehlers-Danlos syndrome, vascular death.
Good evening, everybody. My topic is Vascular Ehlers-Danlos syndrome. Vascular Ehlers-Danlos syndrome, it is a group of heritable connective tissue disorder which is associated with the mutation of COL3A1 gene, which causes defective procollagen. There is abnormal triple helix formation of the collagen, which leads to increased fragility. So the features of vascular Ehlers-Danlos syndrome include hypermobility, skin laxity, and it is associated with increased symptoms like rupture of vessels, intestine, uterus, etc. There is a major and minor criteria for the diagnosis. Any 2 or 3 of the major criteria will confirm the diagnosis. The major criteria include vessel or artery or uterine rupture, skin laxity, characteristic facial configuration, and easy bruisability. There are among 9 minor criteria also associated with this. Usually once the patient is diagnosed, diagnosis is usually confirmed by collagen testing and genetic testing. Once the diagnosis is confirmed, even though the treatment, there is no definitive treatment, we can modify the patient's lifestyle, and we can ask the patient to carry bracelets with them, which will help them to identify risk of rupture if at all it happens. There are specific anesthetic protocols for this, and if the patient presents with any bleeding complications, it is usually managed as conservative unless it is a dire emergency and at risk of life. And they present with a characteristic bleeding, then we have to, like in extreme cases, we have to ligate the vessel rather than approaching for open managements. And endovascular management, like coiling, can be done if the bleeding is associated with ostial vessels like splenic or hepatic. And when it is associated with aneurysm, it is usually managed conservatively because of the increased tissue fragility. And while handling the tissues in vascular Ehlers-Danlos patient, we should be very careful that the plugget, soft clamps should be used, and suture should be tension free, and we should use pluggets. And permissive hypotension is another method by which we can decrease the syndrome complication. Thank you.
Okay. How many types of collagen are there?
Type 1. 4 types of collagen.
Basement membrane contains which type of collagen? The basement membrane contains which type of collagen? So what all?
What other features will you get in a patient of Ehlers-Danlos?
They may have atrophy, hypermobile joints. Then there is a high risk for development of pneumothorax. Then laxing, easy bruisability. Then they may have early onset varicose veins.
What all precautions will you take from your side while doing any endovascular procedure in such a case?
Endovascular procedure is associated with high access site complications in this case. So preferably we should avoid endovascular cases. And open cut down for the vascular access is a better preference. And if at all we are taking a percutaneous access also, we have to use we should preferably avoid, and open access is better. And monitoring the.
No, we should avoid. I know that. If at all you need to do, what all precautions will you take from your side? That's what I asked.
If at all you have to do endovascular procedure, what all precautions you will take from your side?
Proper screening, proper compression, monitoring for hematoma formation or any complications, and
Thank you. Thank you, dear judges and residents. Would like to invite Dr. P.C. Gupta, Dr. Sagar Robinson, or Dr. Shivananda. Patient leaders for us to answer and thank you, Leon. Thank you. Welcome all the judges. We'll start with the first doctor, Dr. Apparna. We'll talk on imaging for CLTI with deranged renal parameters.
Good afternoon. My topic for today is imaging for the CLTI in renal parameters. Chronic lymphatic ischemia is one of the major causes for renal amputation. It can be evaluated with the preliminary investigation, that is Doppler. In Doppler, it's a preliminary investigation, we can see the flow rate, and then comes CT angio, where low contrast CT can be used, non-contrast CT can be used. Then comes MR angio, where gadolinium is used in place of ionizing contrast, and also IVUS can be the recent advances for IVUS, intravenous ultrasound, where it has 2D imaging and in gray scale and white scale, and also HRMRI, high resolution MRI, where the vessels can be visualized without the one.
If you have a patient with CLTI, transferred several pulse absent completed and treated, what is the first investigation that you would like to do to make the patient with deranged renal function?
First, I would like to do an arterial doctor. To see then if CLTI, then I would directly go for a DSA angiogram, conventional angiogram, because it gives us less contrast as compared to conventional CT angiogram.
How good or bad is ultrasound in a patient with deranged renal function who is likely to have significant calcification in the arteries? Is it reliable, not reliable?
Reliable, so it is operator dependent, so we can see firsthand the calcium.
In the presence of deranged renal parameters, would you prefer gadolinium-based MRI, or is there any other form of MRI which you would?
I just
Certainly not high resolution.
Is there any other gas which you can use to demonstrate?
CT angio good investigation. Okay, thank you. Next would be Dr. B. Naveen Venkat, and the topic is voyager period. We find. Good afternoon, respected faculty. I'm Dr. Naveen from Nizam's Institute, and my topic for today is voyager period trial. So voyager period trial is basically it was a trial designed to see the difference between aspirin alone versus aspirin plus rivaroxaban in relapsed patients post surgery. So here the dose of aspirin in the trial used was 100 mg and rivaroxaban was 2.1 mg. So it was basically double-blinded randomized control trial. Initially they included around 6,500 patients per study, and the inclusion criteria included more than 50 years of the patient age, and all those patients who are having distal critical ischemia and who are being planned for the revascularization. Exclusion criteria: those patients having bleeding diabetes or who are at risk for major bleed on use of anticoagulants are excluded from the study. So initially, the number of patients enrolled was around 6,500, but later, because of some of the bleeding manifestations and all, few patients were dropped out of the study. The primary safety outcome, the primary efficacy outcome measured in the study was amputation rates, rate of myocardial infarction, acute ischemic events, NICVA, and the primary safety outcome measured was bleeding risks. And it was assessed based on two different scores, which included an HB drop of more than 3 or hematocrit reduction of more than 15, and any intracranial hemorrhages. So the results of the study included bleeding manifestations. There is no difference between aspirin alone and aspirin levodopa. 6 to 7.
If at all you encounter a patient with bleed, what are your management of?
We stop the anticoagulation if it's being used, and we check for the coagulation profile, public picture, and check for the platelet count and all. And if the patient is having a severe bleeding, then we might think of using a reversal for the anticoagulation.
So was there trial include patients undergoing injection, injection or endovascular?
It includes both.
You know the PI of the study? Principal investigator of the study. So what earlier study led to designing the thinking that will use the pathway inhibition by injection?
Compost trial, which was used in the pre-operative non-operative patients.
So which trial showed better outcomes with dual pathway inhibitor, compass or what?
Compass.
Why do you actually show much better outcomes with dual pathway inhibitor than compass?
Thank you. Thanks.
Next is Dr. Harish G, and the topic is cancer-associated thrombosis versus non-cancer DVT like PE, the key differentiating features and clinical implications. Key differentiating features in cancer and non-cancer associated with DVT usually can be provoked or unprovoked. Usually in unprovoked patients, unprovoked they will have a history of varicose veins or history of varicose veins, and in provoked patients usually surgery, trauma usually possible. In a cancerous patient, usually in old age, suddenly developing DVT, and the patients, if admitted for chemotherapy, and they will be having central line induced DVTs, which will provoke DVTs, and also bedridden. It can also be bedridden.
it comes to morphology, both will have because of in cancer associated is mainly related to tumor biology, increased cytokines and other chemotactic factors and cancer associated paraneoplastic syndromes will leads to the DVT. In non-cancer associated DVT, patients will be having hypercoagulable states like APLA and protein C deficiencies. This will leads to DVT. When it comes to treatment wise, the patient with cancer, usually we have to see which part of which malignancy is having. If he is having GA malignancy or other, we cannot give anticoagulations which we regularly give like Novax and all. So usually for a cancer associated DVT, we start with low molecular weight heparin, we assess the patient for the bleeding risk, and then we can give Novax. Whereas in unprovoked DVT, we can directly start Novax if there is no contraindication. And usually in non-cancer patient, with proximal DVT, we advise for surgical therapy, so interventions, endovascular. In non-cancer patient, we assess the lifespan and whether it is a palliative or treatable. Then we, depending on that, we advise the surgery. In cancer-associated DVT, the anticoagulation should be as long as the cancer is there. We give an anticoagulation till it is curable. If patient is curable,
so in patients with cancer-associated DVT, what are the factors which result in high risk of disease other than cancer?
immobility. If patient is on chemotherapy, they will put on central line, usually that will induce DVT.
Can chemotherapy itself result in increased
chemotherapy?
Can surgery result in increased risk of DVT?
Both it can increase DVT and surgery.
Are NOACs, is there evidence to show that NOACs are useful in patients with cancer associated?
Yes, sir. Useful. Usually, the redundant trials it shows apixaban. They can use apixaban in cancer-associated patients. And also Einstein extension studies showing they can be used for longer duration also.
Are you aware of what might be the percentage of cancer associated DVT in Indian patients? So let's say you see 100 patients with DVT, how many might have cancer associated DVT?
4 to 7%.
Almost 100. Thank you. So moving on, Dr. Pilpi, he will talk about carotid stenosis, evolving intervention.
Thank sir. You're talking about carotid stenosis. In the era of endovascular intervention, carotid artery stenosis is increasingly treated by carotid artery stenting. Carotid artery stenting, however, there is a risk of distal embolization stroke. So, new intervention like PCAR, carotid artery revascularization, to release the sheath in the femoral and as well as one in the carotid artery to prevent distal embolization and to prevent chances of stroke there. Other interventions can be placement of bolus retention devices like proximal distal balloons or a filter device. So filter device is most commonly used device. However, in this there's a study, the PROFI study, in which proximal balloon occlusion is proven to be much better in terms of stroke risks.
Can you just tell us the title of your talk again?
Carotid artery stenosis, evolving intervention.
So So what is the latest intervention that you come across for carotid artery stenosis? How does it score over regular carotid artery stent? Is it better? If yes, what are the advantages? If not, what are the problems?
Advantages is that it is better in terms of stroke risk, sir. There is distal flow, the particles, the distal flow, reducing the risk of stroke. And disadvantage is that the larger sheath has to be used for the procedure.
First, how does it reduce the risk of stroke compared to transfemoral carotid artery stent?
It flushes away the debris which is vaccine.
Are you aware of the procedure? So what causes stroke if you're doing a transfemoral carotid stent? At what steps can you cause stroke?
Passing the lesion, when you're passing the lesion,
anything before you actually get into the carotid artery can you cause stroke?
When taking an angio,
yeah, trying manipulation inside the arch itself will result in stroke. You avoid that. So the patient who has symptomatic carotid artery stenosis, has a TI or a minor stroke, what is the first procedure that you would think of?
symptomatic carotid artery.
So, still we are done.
Thank you.
Next is Dr. Darshan. He will talk about imaging and intervention in a vulnerable carotid plaque.
A vulnerable carotid plaque is one which has high risk of plaque hemorrhage causing occlusion or embolization. So it can be imaged by ultrasound, CT or MRI. In the conventional ultrasonography, we see two things. That is the juxtarenal black area and hypoechoic. If it is more hypoechoic, it is more unstable. And the juxtarenal black area, if it is more, it means it's an unstable plaque. If the total necrotic area of the plaque is more than 95 millimeters square and plus the juxtarenal black area is less than or more than 6 millimeters square, it is more chance of it's an unstable plaque. The newer modalities of ultrasound are there, that is contrast enhanced ultrasound, which uses air bubbles mixed with normal saline that are targeted against the P-selectin and B-cams that are that modulate that have a role in the inflammatory action of the plaque. And there is a 3D ultrasound which can assess the plaque ulcer. A plaque ulcer is one which has a surface irregularity of more than 1 millimeter cube. If the plaque ulcer is more than 5 millimeter cube, it is unstable plaque. And MRI can see intraplaque hemorrhage, large necrotic area, and thin fibrous cap less than 5 millimeter square. And newer modalities of MRI using microiron oxide, they are even targeted against the P-selectin, which indicates angiogenesis, which are role in carotid plaque. And CT and PET-CT can show the inflammatory activity of the carotid plaque. Thank you.
Your decision making whether you want to where you want to go.
The symptom of the patient, if the carotid stenosis is more than 70%, and even though if the patient is asymptomatic, he can go for surgery. The imaging assets, if it is highly sensitive of unstable plaque, and we should go for the procedure.
So when you do an ultrasound, what indicates plaque vulnerability? Hypoechoic or hypoechoic?
Hypoechoic.
When you use contrast ultrasound, what does it offer in addition to conventional ultrasound? You indicate that it might be a 1 2 plus, not selective.
Recap. The vascular angio.
You are injecting air bubbles. How are we going to target P selection or B cam or C cam or anything? If you do an MRI, the standard MRI, is it a good test to pick up a vulnerable clot, or do you need any special MRI to pick up vulnerable?
High resolution MRI.
High resolution. What are the features, clinical features? What are the features on ultrasound other than hypoechoic and juxtarenal black area that might indicate that the clot is vulnerable?
The large more than 500 millimeters and thin necrotic cap less than 50 micrometers.
Anything during follow-up? We discussed it yesterday. If you image today and you image after 3 months, any change in the plan which might indicate that it is vulnerable?
Intrablack hemorrhage.
Thank you. So next is Dr. S. Devi Priya. He will talk about aortoentry treatment.
Mike.
It can be primary and secondary. In primary, there will be contact with the GI tract with the aorta. It is mainly due to the mechanical disruption during the GI peristalsis or any cause of infection, and it is most common in the third and the fourth part of the duodenum, and it can occur in esophagus and everything. And the secondary, generally, in secondary, patient will have a history of abdominal surgery. So there will be contact of a bubble with the aortic wall leading to disruption, and it is most commonly in the distal duodenum. And in this CT, if the patient is stable, then we can do an CT. In this, we can see periaortic gas and aortic gas, soft tissue edema, leak. We can see in this, and if the patient is unstable and everything, immediately you have to shift the patient to. If there is history of any abdominal aortic aneurysm repair, we can immediately take up the patient to OT. If there is no history, then USC can be done and to see for the what is the source of pain. If the patient is stable, we can do DSA, OG, those to inspect everything to rule out the secondary causes of the secondary fistula, and we have to differentiate with the erosion and the fistula. If you're planning for endovascular management, then we can do the BOBO, and stent captation can be done to seal the fistula. We can use coils or plugs or fibrin sealant can be used. Secondary is 0.36%. Primary is
Is the aortoenteric fistula seen only after open surgery, or do you also see it with VIVA? The aortoenteric fistula, is it a complication of VIVA?
If there's persistent endoleak or endotension, or if there's any infection at the time of graft replacement, then after VIVA it can be affected.
Where is the role of oil placement or embolization in the aortoenteric fistula?
When we're doing the endovascular procedure and looking for the sealing the fistulous tract, we can use
called
Is an endovascular option ever a permanent solution for aortic fistula?
No, sir.
What is it? What type of solution is?
When we open,
No, does it provide a temporary solution or a permanent solution? Endovascular. The balloons placement.
open surgery, take control of the aorta, remove the divide and the divide execution to remove it, and we have to provide the extra anatomical or extra relaxation should be provided for the patient. And the patient should be long-term antibiotic.
What conduit can you use to replace the previous surgical graft? I'm expecting Dr. Sudhir Kumar Reddy to talk about Pelvic syndrome, endovascular or open.
Good evening, sir. My topic is Pelvic syndrome. Pelvic syndrome is mechanical obstruction, compression of the subclavian region of the axillary in a first-class stage. Mostly the athletes, individuals most affected are women, and mostly athletes which are infected with doing people who are doing daily exercises. Mostly it occurs in a dominant handle. It is more, due to the subclavian postclavian muscles. It is bounded by medially by the first strip, anteriorly by the clavicle, and posteriorly by the scapula. The patients typically present with pain and bluish discoloration over the shoulder area, and the investigations are ultrasound Doppler, which in which the clavicle will mark the pathology, and we cannot be we can't do it, we can't see the pathology definitively, and we can go for venography, which is the gold standard, and patients who might have require intervention. The intervention is of two types. If the patient is having on Doppler VPC and acute pathology, then we can go for venoplasty. We can acute pathology, we can go for a pathology. If it is a chronic pathology, we can continue anticoagulation. When it is a mechanical compression, you can go for a surgical decompression. After surgical decompression, then you can take a chest venogram after 2 weeks. Then if there is persisting stenosis or occlusion, we can go for plasty. And if there is no as such, the patient can be kept on surveillance with anticoagulation.
You're supposed to talk only about endovascular versus surgery, not really supposed to describe. But since you described, I'll ask you something. Do you know any other name for Pelvic syndrome? What is the structure that causes mechanical compression and injury to the subclavian artery vein, which is not this? Once you do thrombolysis, what is the next thing that you would like to do? Do you think there is a role for only endovascular management of Pelvic syndrome?
No, sir. There is a stenosis which can be corrected, then only we can go for an endovascular. But if there is mechanical compression, we go for a surgical.
So you have a patient who has come with acute Pelvic syndrome, acute thrombosis. You don't know if there is a mechanical compression. What is the first step you would like to do? Let's say patient is young, we want intervention. What is the first thing you will do?
Acute thrombosis. Then I go for a tachycardia. After doing the thrombolysis, I will again recheck with the venogram. If there is still any lesion which needs to be corrected, which is creating the thrombus, I would like to go for plastic.
Do you think there would something which will be compressing the vein? Do you think the plasty is a good solution for some external compression of the vascular structure?
No, if there is any external compression, we need to go for a surgical.
So is Paget Starter syndrome a result of external compression or just happens sometime? Next up is Dr. Dilip Soni. Topic is persistent sciatic artery vascular inflammation.
Good evening. I will be speaking about persistent sciatic artery vascular inflammation. Persistent sciatic artery is a rare neurological abnormality representing less than 0.1 to 0.05%. Persistent sciatic artery in the embryonic life, it originates from the internal iliac artery. It goes along with the sciatic nerve and joins the cochlear artery. In the third week of gestation, as the iliofemoral artery develops, the sciatic artery regresses and completely disappears or remain as a small branch of the inferior gluteal artery. The persistence of sciatic artery results in the formation of persistent sciatic artery. Pelvic and gluteal are classified persistent sciatic artery into 5 types. Clinical examination, in case of aneurysm, it can present as a gluteal mass. And COVID side, it is present in persistent sciatic artery where a femoral pulse is not palpable while a popliteal pulse is palpable. The vascular implications of persistent sciatic artery, one is aneurysm formation. Since the persistent sciatic artery is more superficial in the buttock region, it can be useful for more trauma and aneurysmal degeneration. Around 50% of the cases can present with aneurysm. Thromboembolic events due to embolization from the aneurysm can present as acute limb ischemia. Then nerve symptoms due to compression can occur. Then the investigations of ultrasound, Doppler ultrasound, or CT or MRI to show the relation of the persistent sciatic artery. The treatment management into asymptomatic persistent sciatic artery do not require any intervention. Imaging follow-up only is required. For the symptomatic persistent sciatic artery, surgical intervention is preferred. For aneurysm, dissection around the aneurysm is avoided so as to prevent the injury to the sciatic nerve. Interposition vein graft is preferred, or ligation of the aneurysm followed with surgical bypass is preferred. Thank you.
Okay, then come back to the same region. How would you do for a persistent sciatic artery aneurysm? If you put an interposition vein graft and then coat the artery to the same region again and subject to persistent trauma, or would you correct the course? Our sentence was interposition vein graft. So, would you do that, or would you correct the course of that? You have to correct the course of that.
So in the first and second type, you have a complete persistent sciatic artery is persistent, and femoral artery type 1 it is a complete femoral artery. So you will be getting the femoral pulse and popliteal pulse. In type 2, it is depend 2A and 2B depending the femoral artery is partial. 3, 4, and 5 very superficial femoral artery is persistent sciatic artery partially formed, not complete. In imaging, we should identify femoral pulse is not palpable and popliteal pulse can be palpable. Yes, sir.
Next is Dr. Supera. The topic is mid-aortic syndrome, diagnosis and treatment part.
Non-inflammatory, non-occlusive narrowing with the distal thoracic aorta and abdominal aorta involvement of the liver artery. It can be communicable acquired, currently called syndrome, neurofibromatosis, tuberous sclerosis, Williams syndrome, and Antegrade syndrome, and acquired carotid that are also added at coming to infections. So these patients usually present with hypertension, Which can be diagnosed by CT angiography. And the management includes the endovascular and open surgical repair. Open surgical repair is usually treated by endovascular repair. Endovascular repair is used for open surgical repair includes aortic bypass. And in children, it can be treated with a tissue expander also in different stages to expand the normal movement of the aorta. You can do aortic bypass in the later stages. If the patient is going to endovascular extension, it is not considering the medication, you can do pneumatic implantation also.
What about the extrahepatic bypass which you can do to treat with that? They don't take the inflow from to treat the inflow. One anything else?
What about the human aorta? I'm not saying isn't in the aorta. Give an option. Endovascular options. One of the etiologies carotid arthritis. If the patient is managing better with the etiology of diagnosis of the patient, so we still go ahead with your endovascular term for all your patients without knowing the etiology. Maybe you can open surgery for this kind of things. How do you know that? What is the choice of graphs that you would put in these patients? Why not use last one is Santosh Monica. Point out an idea when to interview.
Idea of the lumen stenosis causing extensive compression without any associated thrombosis. It is more common in females in the ratio of 3:1 and second to fourth year of the life. And symptoms include heaviness, varicose, edema, pain, discomfort, symptomatic to chronic severe changes. Women with aneurysm presents with chronic pelvic pain, dyspareunia, vulvar swellings, and lower extremity and pelvic varices. The main role of the treatment is to visualize the compression and rule out other causes of the edema and to plan the treatment strategies. And investigations include duplex ultrasound to visualize the compression and to visualize the compression, extensive compression, and to rule out other causes like DVT and thrombosis, and CT and MR venography, mainly to rule out compression and collateral flows, and catheter directed thrombolysis, and IVAS to mainly to identify venous spurs or the webs, and for planning of the treatment, and for selection of the stents and measurement of the vein diameters. Treatment asymptomatic patients with instantly detected NIL does not require any treatment. We just counsel the patients regarding the DVT and future DVT and CVL. We just give compression stoppings to the patients. And symptomatic patients require edited, there should be edited inflow and outflow. Plastic with stunting is ideal in these NIVL patients. Wall stents and most probably.
What is the role of catheter-directed thrombolysis that you mentioned in patient with an IDL? You said catheter-directed thrombolysis. Which is the diagnostic test to detect the NIVL? Does presence of NIVL increase the risk of atrial thrombosis? Sure. So does that mean that all patients with an IDL should be stented? Would you still like to use wall stents? Are of course extensively used, but in today's case, would you like to use a wall stent? I don't even know what question I'm going to ask you. So one thing for all the students, at least wait for a question to be over. Sometimes you know the answer, but it may not be for the question that I'm asking. So wall stents is wall stent a self-expanding stent? The question is based on your statement. You said wall stents are used. So there are dedicated so wall stent is also very expanding.
आशीष ने नोट करा दिया
हाँ आशीष ने इन्होंने दो दिए नहीं
Which is the commonest
वन
ये वाला देख लो खोल के देख लो
ये वन है उनका
देखो
We have one more.
नहीं ये बात
है
अच्छा
last one is strategies to reduce radiation exposure.
ये वाला अभी चलाना जब मैं पहले बोलूँगा
अच्छा ये पहले
फिर जब बोलूँगा वो बात
in people working in cath labs and radiation exposure is a threat to our safety, and radiation can be a ionizing and non-ionizing type. The ionizing radiation is a harmful radiation, and this radiation, the effect of the radiation can be of two types: deterministic type and stochastic type. In deterministic, it is dose dependent, and the more the exposure to the radiation, the more the effect on the tissue. And in stochastic type, it is not dose dependent, and beyond the threshold, the changes start, and it is not dose dependent anymore. This is usually due to mutations. And then coming to there are some safety protocols, and the amount of radiation exposure in certain professions have been calibrated, and generally, overall, less than 20 millisievert per year in professions exposed to radiation is the first safe level. And coming to the practices that can be followed to reduce the radiation effects in a cath lab, when we are one is the time the usage of higher voltage and lesser currents, and using a larger image intensifier, and keeping the image intensifier and the patient close to reduce the scattering, and then using less using pulse fluoroscopy instead of continuous fluoroscopy, and reducing the time of fluoroscopy, keeping the amount of DSA and semi-fluoroscopy that we use to a minimum, and then the distance between the patient and the doctor, and this decreases by 4-fold, and then coming to the materials used to protect ourselves, there are what materials can you use to protect yourself? lead aprons are used to protect ourselves and the thyroid shields and even head caps. Then coming to there are some eyeglasses that can be used and then we have ceiling mounted and table mounted acrylic or lead shields. Then
What type of lead aprons would you like to use? Front covering or round the top?
Front covering which crossover are better which double.
So you don't want to protect them.
No. Yeah.
What is black type with respect to the patient? With respect to radiation here, what is black? Is your protective material only lead, or are there any other materials which protect? What is available? What is the problem with lead? So what is there to reduce the man?
What is the problem with it? Why do you want to impose a week? Okay, you feel tired. One, what else? You about the cake on the side. Anything that you can place on the patient to reduce radiation? Anything that you can place on the patient? We are done with the Extemporaneous section. Thank you, David, for your valuable
वो स्क्रीन मिरर है So exhaustive and mind-boggling the whole day. But we'll divulge a little bit here for the judges also and for the students also. It's been quite a long day, I understand that. But then this was required. So what we are going to do here is that tomorrow morning we'll be having an informal discussion as we have every year. This is the time when there are certain queries, questions with regards to the fast-moving world with your clinical practice, what you should do, what is right, what is wrong, what is the legal aspect of branding, what is AI going to do, will we be debunked someday? Then social media, which is catching up so fast, there are certain rules and laws of Indian government and the ministry which we have to be apprised with. So what we are going to do in the next about half an hour, 45 minutes is that we have devised a panel of people who are doing these social media things. They are talking about AI. They are talking about how to manage their OPD schedules, how to do their branding online, their websites, what should be done for you guys. So we have kept a panel of 5 people here. So I'd like to call upon all 5 people on the stage first. Dr. Himanshu Verma, who is the leading vascular surgeon at Fortis Gurgaon. Dr. Ashish Aaron, who is with a vascular surgeon in Jaipur, one of the 4 in Rajasthan. I would like to call Dr. Ashutosh Pandey, who is the second vascular surgeon of UP. He's built up a good practice. You see him everywhere online. You see him everywhere roaming around here, also doing all the background stuff. He is with Tender Palm Hospital, Lucknow. Then Love Luthra and our beloved Apur Srivastava, who is the treasurer VSI, who is the senior consultant in Sir Gangaram Hospital for practice building that we are going to talk about in a question answer manner. In between, to have a little, scientific content also, we'll be having small industry presentations about credence, BTK stents, about the anticoagulants. That will be having a short presentation before I will call them to give their talk here. So, love is there. Love. Love is in the air. So first of all, I'd like to start with Dr. Himanshu Verma. He'll be talking on AI for doctors, practical applications in daily clinical needs, medical research and personal branding. Now after that, after his presentation, we'll be having certain views by Dr. Himanshu on how regarding the journal, what is right, what is wrong. I will also be speaking as the editor as to, the articles are being written by AI, presentations are being made by AI. Everything is done by AI. So what exactly is the viewpoint of the journal? We'll be talking about that. First of all, Dr. Himanshu, for your talk.
So I'll simply do what we all have been doing in our past time these days. Can you get this on, please? Okay. Who in hall has not used ChatGPT? Good. I didn't expect anybody to. But what we are going to discuss is we keep on listening, Bill Gates saying that AI is going to take a lot of jobs of doctors and something like that. So what is AI for the doctors? Practical application. So I'm not an AI consultant, so do not ask me. I do know, but I won't be discussing what is the machine learning, what is neural flexi learning, what is language models, but rather we'll discuss about how we can utilize AI for in day-to-day clinical practice, how we can use this as a tool in research and publication, and then if we are using, how it can help us in our marketing and branding. We all have seen this. Perplexity, some of us have known about this. Gemini, Grok, Notebook LM, how are they different? So take AI as your, not as a teacher, take it as your very intelligent immediate junior. So if you are a consultant vascular surgeon, consider AI this as your PG first year. When you start interacting with it, maybe even junior, when you start talking to it, then as you interact, the knowledge of this junior grows, and up to a segment, it will become like a PG third year. But what they say in Hindi that guru रहता है, लेकिन यहाँ पे चेला शक्कर नहीं हो जाता है so far. That means till point AI has not reached to a level that it will cross human minds. Okay, so we have to keep that in mind. Now there are a lot of things available. Now, most common is ChatGPT. We all started using it, and because it has been fed up by so much of data, so far ChatGPT has been performing better. But equally, Perplexity, if you have not used, I will always suggest that everybody must explore each of them before we, we land up in choosing which is right one for us. Now, in general, for, what we use and we refer as AI is generative AI. Okay, there is LLM which is a subset of generative AI. Generative AI is a bigger picture. So based on the previously trained data sets and what things have been taken from your side, it can generate a language, a music, text, videos, so different kind of outputs it can give. Whereas LLM is specifically made, large language models are specifically made for the language. So in general, they only produce text. Some of them have mixed properties, and here we will stop. And so coming here, so like generative AI, when you're using ChatGPT, because it can also generate patient education video, it is better. It may be better for your marketing and branding also. And but when you're coming to hardcore research, looking at the language, usually LLM models, the one notebook LLM which I'll show you, these are the better ones. So now let's go to the real time. So we have a ChatGPT. It comes with a free version, paid, and then pro version plus. Most common to utilize a lot of things, you do have to have the paid version. $20 per month is what I've settled down. So I've used the $200 also, but then it came down. It gives you a lot of extra leverage. Now, what was the last? Let's begin with some tasks. Before that, you should know this is the area. It also comes on a net, and that we all know. But we should also always look for the app part. Okay. Because in app you can summarize, and it's readily available on your phone rather than going on your browser every time. Now, if you look the segments, you have this prompt area which opens any chat like this, but you also have a project side, so you can organize your chat. If you look, I have today's program, or the program which I'm making AI for doctors, patient OD notes, vascular hardware, query reply for international. So there are different things. So the project is very useful because here, if you look, like this is a query reply for international patients. So when I get patients' queries different and they come 50 pages, 25 pages, you don't have time to read all of them. So, but before ChatGPT came in, I used to have certain things written, maybe 100, 200 responses are given. So all of them I have put in. So what my knowledge I have put in, and this is my standard protocols, or maybe like 100 responses. Then here I have written, okay, this is, I'll be needing a response for, for the patient, for the generic information. Patient is coming from overseas, I guess. So I simply tell it that I'll be getting the images, some of them may be incomplete. Please gather the maximum text and give me the recommendation based on the diagnosis, the plan of treatment, also the cost. I also mentioned that cost mentioned in the files attached are old ones, so please increase them 10% more. And then, so let's upload some files. Okay. I don't know if they are visible here or not. Now, patient queries. This is, I just go and generate and I write reply. It all depends how slow or fast your internet is. Yeah. So, like I have told, I want a working diagnosis based on the information provided, tentative to medical advice and treatment plan, so immediate recommendation, surgical, cost estimate, it has given. Okay, now suppose this patient, I will not put it, I have already read this patient because this is not the master. So I read this patient had a distal embolism. It also had some pictures of feet, but it also mentioned that patient had aortic mural thrombus. Now in this, it mentioned in treatment plan, it mentioned to go on a high level of anticoagulation, not mention anything about to do anything with the mural thrombus. That's why when you use AI, you're not supposed to take everything blanket. Here, I just uploaded. Okay, I have. Then I don't have time to write. So this is a paper. I want a recommendation based out of this also. This is I'm using the transcription part. Okay. So now it reads immediately and it gives the updated recommendation based on this paper also. Now this will also include the surgical part for the PM. So this is your day-to-day learning channel. This was one example. Now second example we can see is, say I just had a surgery, I was rushing back. I didn't get time enough to write my OT notes properly. So can you help me? Okay. Please write a OT notes for right femoropopetal bypass. It was a standard femoropopetal bypass using a 7 mm PTFE graft. It's with vertical common femoral and abovenopopetal exposure. However, popetal artery had a thrombus and some chronic plaque. I did a popetal endarterectomy and did a patch using pericardial patch. So please prepare a detailed OT note summary. OT notes. Okay. You have structured notes. Now again, this all is gradual learning. When you start using, maybe you will have some different formats. Like here in my chat GPT, I do have a patient OT notes area sometime when it started. This is for the example actually I did. So this is one learning. Now, what else we can do with this? Well, you have taken a reference from, say, cardiology, but something you are not very particular about. You want to learn something. You simply are driving and you wanted to learn something today. So let's start a new chat. And now we are going to have so far we are using the transcription. Now we are using the real-time voice chat. Hi. So I have been looking at the edema from the perspective of looking at the call. So it's a unilateral or bilateral edema. But if I look at the leg edema, is there any way per se I can image the local area at the leg itself and maybe then further proceed towards the cause? Well, actually, I was not looking for Doppler per se. I was looking for high-frequency ultrasound. And can high-frequency ultrasound change something what we look on a routine basis?
Oh, absolutely. High-frequency ultrasound is super detailed and can give you a really clear picture of the soft tissues in the leg. It's great for looking at things like superficial veins, lymphatic channels, or even the subcutaneous tissues.
Is there a way we can actually classify? So, okay. Now the thing is, this is the discussion which I had with ChatGPT long back. You can just explore whatever you want to learn. One more thing, Kabir, we remember these kind of images when we go to conferences. We all take in our phone and then we forget, right? So what if I'm sitting in a conference and I tell, okay, so I'm going to a new conference here. I'll be taking pictures and please keep this in mind and give me a summary later on. Okay. And then I have like some pictures I have did last year. Okay. So when you're, I think you can keep on taking 5, 10, 50, 100 pictures. And when you come at the end, it will just give you everything. Okay. Not everything. You can use this as a basic knowledge. Now if you want to explore something. So here, well, there was a specific study mentioned in few of the slides. Which was that? So it does find that reference study. Okay, you can have an individual picture. You can keep on searching inside that. So it makes your job easier. I sleep off in lot of conferences, but I know they're useful for me, and especially when when I was resident, I used to sleep even more. But sometimes they're very important images. and the images just remain with you forever. So this is the way you can actually have a takeout, and when you are going back, traveling back, you can just go through and then you take the points which you want to explore more. Now coming to research. Okay, now I remember I said LLM notebook. That's one of the very fantastic way, because see, 60 pages guidelines came in, and you don't have time to hear. What will you do? Okay, so here I'll just show example. So like ESVS guidelines, I just uploaded. I'll show you. This is okay. So I added here guidelines, and here there's an option to generate. I will show you that later, but
where we dive into the latest 2024 guidelines on the management of peripheral artery dysfunction, or
so you can listen to this entire guideline in a format of a podcast when you're heading home.
Published by Gordon and colleagues, representing.
Now, if you want to go deeper, here you see there's a deep dive conversation. So you can actually decide you want a two-host conversation, or there's a coming up also. When you come up, there's an interactive beta mode. So you can become a third person who can be interacting with this. So you can actually talking AI through this paper. Sometimes this comes very handy and very useful. Now, again, the limitations are time is limited and things are too much. It's very important to come as a personal branding in social media. I'll give a small example. I wanted to post something that, the different specialties become so centered that one person cannot look at it all. So I wanted to have a LinkedIn post. This video was generated by AI, with a prompt. So again, there is no sound. Again, coming to very important part is it right always? Yesterday we were trying to just, the question paper, we took a picture and put it on ChatGPT and looking at whether this gives answer correctly or not. So one of the answer, it was repeatedly giving wrong. Okay, but so AI does develop hallucinations. This paper it was just published in this June itself by Apple, which is about illusion of thinking. It's a different ball game, but yes, AI is not always right. So what we can do to make it right or make it better? That is a totally new branch coming up. It's called prompt engineering. So a lot of jobs gone, a lot of jobs come up. What you have to understand, you have to give it really right prompt. So write the OT note for Carotid and that, okay, it will give it to you. It will give a very standard format. If you ask write Carotid and that to me with this approach, and if you give some description of plaque or some patient, and then you discuss, then maybe probably it will be much better. Okay. And at last, remember, AI is an assistant. It's not a master. Remember, there was a time when we all used to feel now that, doctors and patients have gone apart because rounds are being taken in, not in wards, but sitting in front of laptop. So internet has pulled doctors away from the patient. So AI, if maybe in one way can actually make doctors even further from the patient, but if you use it intelligently, use it to save your time, so that extra time you can use for yourself, you can use for family, and same time you can also improve patient experience. So thanks a lot, and anybody who wants to, I'm just explorer, so just keep on exploring about AI.
This question, I would not qualify the question per se, but something on the topic of the came across and it was very helpful. So, patient which was a complicated case operated outside, the relative working in IT, and they are more sound in all these things, they are developing it. So, one of them just put it in, that research committee, they put it in the ChatGPT. They asked ChatGPT what are the chances of medical negligence in that. ChatGPT created a whole report where the negligence could have happened, what is the time duration that was missed. So I feel it is more of a double-edged sword. For us, it is beneficial.
See,
but how to go about it? I mean, it is going to happen rapidly.
it's very important. So now it's other way around also. When we used to fear when patient will come with Google because their Google search is going to be totally haywire. But same time, you ask patient to, when you're taking consent, okay, ask him to go actually go and put the consent on patient surgical risk across sector. So don't let them wait for some complications to happen. So they are more likely to understand that if the patient has got 22% EF versus patient is a normal person, why the invitational rates may be higher. So see, it's not up to you, patient is going to use or not. Patients are going to use it. Okay. The best case scenario is still the old school medicine was the best. But if it is coming as a tool, somebody who is going to use it and understand it before. So as a protocol, my team, before consent form comes to me, my team is vetted. They know that they have to find what is the individualized consent form for the patient. So then on top of that, I fix one or two things. So use in the positive.
Thank you. Fascinating, mind-tickling talk by Dr. Himanshu. AI, make this radio carefully, give you fistula. This is the way, this is the artery, but still you will have to do it. I have many AI with me who do this thing for me, make this thing. So they are my AI. But disclaimers, this midterm meeting, there's a lot of AI involved in this at the back end. What we are trying to tell is that, as in the last slide he said, that they will not be our masters, but we have to adapt. Yahoo, British Mail, people do use it, but Google took over. They had to adapt to the changes. And that is what we are trying to tell here, that PC sir is there, Vivek sir is there, Sharmila ma'am, Shivanand sir. Everybody is gradually changing every day because this will take over. And if we use it properly, all these tools, when we used to hear, either not for me, for engineers, for software people, vascular surgeon, what will we do with this? But then you have to make it your assistant and you have to listen to all this and try to adapt. The guy sitting here has an AI glasses on his eyes. He was trying to solve the paper looking at this. That's why we kept all the mobile phones outside yesterday. Because I thought that if this happens, we are on a different ground altogether. Other people sitting here, they are generating their notes, they are generating their codes, they are generating their discharge summaries, they are taking help of, and everything that you are doing today, mobile phones, all the gadgets that you are having, is having that, and we need to get on with it. From the journal perspective, just 2 or 3 things that we had some papers by a general specialty guy from outside India, from Egypt. He sent 8 papers on vascular surgery. 1 month back, he had written 8 papers on neurosurgery. 1 month back, he had written on ortho and eye, and those were all good quality papers, review articles. Now, those add value to the journal, and they do not go into plagiarism. Plagiarism will be when they are copied from somewhere. More than 80% copy, more than 90% copy, you have to reject it outrightly. But then we were in a fix from the editorial board whether this should go into the journal or not. Now that is AI generated. We know. So we have to catch him somewhere. The references were not falling into place because AI will have some lacuna. It cannot be perfect because that is what you are feeding. Now today if you ask where is the Vsi Mid Term being held, all are attending, it will give you everything. Who is doing what, till what is happening right now, but it will have some error. So that is what you were talking, that it will take out our errors also. Right. But then what we did was, we went through, because we try to evolve on the world standards, JVS, EJVS. So JVS, there was an article by the editor. He wrote on AI. He generated that editorial through AI and said that this is wrong. So what he said was, there were 3 or 4 things good, 3 or 4 things bad. He said the ethical part, the practical part, it's helping you in writing. You use it for that. Then we will have to use some tools to identify whether this is AI driven. if the proper credit is given, because that is not knowledge transformation to you, because what is your experience, what is Shiva's experience, what is TC's experience, we need that written properly. That is why we are doing manual presentation and AI presentation करवा देते हैं. Extempore की तरफ. So that is not counted as plagiarism. But if you are writing in the disclaimer that this is AI generated, then we have to have a limit that more than 30% will not be accepted. We need to enhance knowledge of people, but gradually we know that you guys will also be submitting papers through AI. And what will be the stand of the journal to publish it, get into bad light that all your articles are AI generated, or have a limit that this is ethical, this is non-ethical. So taking help is ethical. Full paper generation is not right. Plagiarism, it is not counted into that, but well, use it judiciously. Now we have more people here. If you have any questions, yes. Shiva. More compact. For example, we need to reduce the sentences to 1,000 words, and we have sometimes we may structure the patient, but we are doing more. So we can reduce into certain. That is allowed, right? Again, language changes when we use the AI, so that is allowed. But copying from our article as a paragraph. Yes. So that's what I'm saying. That enhancing, making it humanoid, you can do it. You can ask ChatGPT to make it more research oriented or enriching the language of that. But don't say write an article on bioabsorbable stents of 1,000 words and with references from 2022 to 2025. Oh wow, well written article, tomorrow I'm submitting. So that's not right. What Shiva is trying to say is that you make up a material, put it up, ask them to generate this much with the references, so that can be done, but not a fully written. Any questions, any queries from your guys?
So a lot of journals now, when you submit the article, at that time they ask whether AI has been used. Do we have that part?
Yes. So still we don't have that, but we are going to have a you have a consent form. So regarding the disclaimer, this was the issue that we are discussing while the submission, you have to give the disclaimer like an ethics committee approval that have you used AI, what part of it has been AI generated. So you have to put it up for the submission. But there is a lot of things involved with the publishers because we have applied for some indexing. So their protocols we have to go through, and then we'll be putting this up, a tick mark kind of a thing, or a submission box where you will have to write certain declarations or the conflict of interest for that. Any other questions? Feel free to ask. We have the panel. Himanshu will answer or. Okay. So from AI, we're going to practice building. This I'm just trying to make it more interactive, practice building, social media. So first, a small industry talk on sirolimus eluting bioresorbable scaffolds, the Make in India stent that we have. Dr. Apur will talk, and then we'll talk about the concept of practice building, how he has built his practice in Gangaram Hospital, wherein there are 10 consultants, but he is also one of the leading practitioners there. Dr. Apur.
Hi, good evening, everyone. Okay. So, I'll discuss about the global outcomes of bioabsorbable scaffolds in the tibial arteries. So, all of us are familiar with the use of stents in the BTK vessels, and there have been numerous articles and research previously. What are the pros and cons of using stents in the BTK vessels? So, this is about the theoretical part. CLI, peripheral arterial disease, most of our patients come with those symptoms, and the incidence is 220 new cases per million populations. Intrapopliteal arterial occlusive disease, definitely it is a leading cause of CLI,
and significant healthcare costs are involved. And it is highly prevalent in low and middle income countries. In India, the prevalence of PAD ranges from 7.6 to 26.7%. So there are certain issues to be addressed. And what are the challenges of PAD in India? It has got a significant burden. We get to see many patients year by year. The number of patients and the footfall increases. The current management, there are different operators have their different perspectives, and most of us follow the things that are given in the literature, what we have been trained about, and what we see that recent advances in the conferences and meetings that we attend. Still, every time there is a need for improvement, and the primary care physicians who handle the majority of PAD patients require upgrading in diagnosis and management, especially in the early disease stages. So, what are the traditional methods? We all are familiar with PUBA, that is the plain old balloon angioplasty, and it is the graceful therapeutic approach. What are the challenges with PUBA? Definitely, all the research shows there may be post-dilatation, dissection, elastic recoil, vestibular stenosis. Due to endothelial inflammation, there may be early complications, there may be late complications. Then the second is bare metal stents that we've been talking about. Then the latest kid on the block is drug-eluting stents. Now we have many of these stents available in the country and in the inventory of most of our institutions. It inhibits the growth from endothelial inflammation, improving the stent patency. What is the challenge with a drug-eluting stent? So any kind of stent, what is the challenge? So you have left a metal bracket behind, and then there is a rule that there will be some kind of internal hyperplasia, and at a point of time that stent will go down. Coming to the drug-coated balloons, immediate outcomes are very, very promising and as compared to the traditional therapy. But again, there is a challenge of re-stenosis and the patient coming back to you. So because of all these shortcomings, definitely there is a need for bioresorbable stents. And the most important thing, leave nothing behind philosophy. It provides just temporary support and then it dissolves after healing. And it focuses on natural vessel healing. So these are the various studies that have been done worldwide, which have used bioabsorbable scaffolds in the BTK artery disease. So these are the 6 of the very famous studies, and they've used everolimus and sirolimus, the different balloons. Good patencies at 1 year, but there are certain shortcomings of these studies. These are not long-term studies, and many parameters, many lacunae are there in these studies. So coming to the Credence BTK trial, which is an Indian study, and PC Gupta sir and many of our senior vascular surgeons are part of this study. This features a bioresorbable PLLA, that is polyl lactic acid scaffold, 100 micrometer, designed to naturally degrade and reducing long-term complications, or rather I would say long-term patency rates. These are available in various diameters, 2.5 to 3.5. So that is the most common diameter which we get to see in BTK vessels. It incorporates a platinum triaxial RO markers for positioning, because the main frame of the stent is not radio opaque. So it has got markers which are radio opaque. So you can just see the marker from the angiography and not the stent. The rapid exchange system, which is commonly the monorail system, ensures ease of delivery and the pressures ranging from 9 to 16. Again, the rationale for the study was to check the results in Indian patients, and the study design was around 30 patients were included. All the assessment, baseline assessment, informed consent, and the demographics, everything was noted. There was a 1 month clinical follow-up, then 6 months clinical and angiographic follow-up, followed by a 12-month and annual follow-up up to 5 years, which is still being done. The safety endpoints were major amputation or any cause of death, and they were different performance and imaging endpoints. So the results of the study, these were the baseline characteristics: single vessel, double vessel, triple vessel, medical history, including all the comorbidities and incorporating the EBI. The scaffold sizes which were used in the study were length up to 40, starting from 19 and the diameter starting from 2.75 to 4. The procedural details: access, most commonly the femoral arteries were used, left in 18 and right in 12, and this was the average scaffold length. Pre-dilatation and post-dilatation was done in a few of these patients. So when we come to the results, there was an improvement of API which was seen from baseline up to a 24-month follow-up. And again, there was a significant improvement according to change in Rutherford record class from baseline to 24-month follow-up. Angiographic assessment, there was a lesser late lumen loss, and the primary patency by ultrasound was satisfactory. Even with angiography at 6.6 months was satisfactory. So clinical outcomes up to 3-year follow-up were also promising, and there were no TLR observed up to 3 years in these groups. However, there were some deaths and major amputations. So now, when we compare with the other trials, the previous VTK favored early outcomes, and there was a significant improvement in the Rutherford class and API. So I'll conclude my talk. Take-home message again: peripheral arterial disease, the prevalence is increasing day by day and year by year, and new technologies are being invented. So when we want to do the best for our patient, so we have to adopt the best technologies sometimes. Results, definitely these studies are not adequate. A lot of research is still needed. A lot of long-term follow-ups are still needed to make it happen. Thank you. Thanks.
Thank you, Apur. We won't talk about this presentation. We'll talk to him about practice building in a team. So we'll be having the discussion tomorrow morning, individual practice, team building, team practice, what you should choose, where you should go. But first, I'd like to ask Dr. Apur, is there, since the beginning with Sir Gangaram Hospital after he left Jivas, and since then, what is your formula for telling to the people here? 5 points regarding the teamwork and practice building, what will you recommend?
Okay, so I'll just answer this question in 5 points. The first point is select your patient and the therapy that you are going to offer very wisely. Okay, and that comes with years of practice. The 3 years of your PG is sufficient for theoretical knowledge. But when you come to the practical aspects of a practice and you have to handle the patients come to you in your OPD, that now you don't have to answer anyone or you don't have to appear for an exam. You have to do the best possible for that patient. So learn with each and every patient teaches you something. So as you grow your practice, once you come and practice, try to select the patients for the appropriate therapy. All patients are different, all diseases are different. So select your patient properly and offer the best therapy to your patient. So that is point number 1. Point number 2 is definitely many of us who completed our training together. So some went into a team and some started individual practice. Definitely an individual practice is very tough rather than practicing in a team. Practicing in a team makes life much easier for you. You get to learn from your seniors, and then your juniors are also there to help you. So I would say whenever you finish your BNB curriculum, for initial few months or few years, try to be part of a team and try to be in some kind of institutional practice, because never think that you will learn all the things during your 3 years of BNB. There are many more things and many practical aspects. Once you become a consultant, you have to learn. So my suggestion will be, if not lifelong, then at least for initial 6 months to a year or 2 years, depending on your perspective, try to be a part of your team, analyze yourself, and then maybe you can start your independent practice. Then coming to the third point, definitely never think that if a new technology has come, like Dr. Kapish was saying, that no, it is not for me, I am comfortable with the old and traditional methods. Never develop that thinking. There are, as endovascular interventions, you are getting so many technologies which are coming, there are too many new kids on the block. And once you start using these technologies, you get accustomed to the outcomes, the handling of these technologies, and definitely not all of them, but many of them, you'll get much better results in your patients as compared to the old traditional methods. So be ready always mentally and physically to adopt a new technology. Do your self-assessment whether you are comfortable with that or not. And if you are not comfortable with that, you are not seeing good results in your patient, then it's okay, you don't use it. But definitely never say no since the beginning. So the fourth point is each patient that comes to you, you try to do the best for that patient. Okay, you are not treating or gangrene, or you are not treating an angiographic image. You have to treat the patient as a whole. Okay, so start your evaluation. When you get busy in your practice, sometimes you start missing the initial teaching that we have received about the basic history taking and examination. So develop a habit, give some time, sit with your patient, talk to the patient. A basic history and examination is very, very important. Sometimes if you don't take a proper history and don't do a proper examination and just rush with the procedure, definitely you will land up in some kind of complications, or you will not get your desired result. And then you will later on you will regret that if I would have taken a good history and examination, my results would have been better. So most of you will start practicing in the next 1 year to 2 years. So develop this habit since the beginning, and whatever you have been taught in 3 years of your teaching, try to apply all those things. I think anything else?
That's good. Regarding personal branding, we're talking about social media. Regarding personal branding in a team, how do you manage the negative branding about others when a person comes to you with a purchase of the other consultant of your team? You are doing a personal branding on your files, on the social media. Others are also doing, and their plan is different. Your plan is different. How will you suggest not negating or sugarcoating, or what will you do?
Right. So that is actually a different question, a difficult question. So when you are practicing in a team, and I'm practicing in a team where we have 9 consultants, many of them are senior to me and some of them are junior to me. So one thing I never do is telling a patient that someone who has advised you something is wrong. Never do that. Never. So if the patient comes to you, sometimes I face these situations. The patient comes to you and says that I went to the other consultant and he has advised me this therapy. So, but I did not like his attitude, or maybe I am not going in favor of this therapy. So, is there anything better that you can advise me? So I start talking to him from the word that whatever therapy has been advised is the standard care of treatment. And if you have come to me with a trust, okay, I'll try to do things better, but I never negate that the other one, whatever the other one has said, has been wrong, or I will do your treatment better than the other one. So it is not a competition. Never take it as a competition. It is only when the patient comes to you after visiting others, that means the patient has a certain kind of trust in you. And for that patient, definitely you have to maintain that trust starting from the history and examination up to discharge of the patient. So you have to do the best therapy for him. And talking about personal branding, see, the best thing you definitely today's era, most of the patients, maybe 60 to 70% are the younger lot who have done a lot of research, and then they select their doctor, and even they know about the disease, the latest kind of therapies available when they come to you. So at least create a website of your own in which you put all the information related to various kind of vascular diseases, and what is the treatment available and what kind of treatment you are doing, what kind of treatment you are offering. because definitely internet is one media which connects you with the patient. So once the patient, when you treat one patient, you give your card that this is my website. You can visit the website. You can learn about vascular diseases. So in his family, in his neighborhood, in his village, if some other patient is suffering from the same disease, definitely it will click his mind and he will ask that patient that this is the website. You can visit about your disease, what treatment is available, and you go to that doctor. So definitely some kind of internet publicity in the form of a website is very, very important. And personal branding should be a part of your brand.
Information portal. Thank you, Dr. Akut. We'll talk more on this tomorrow morning. Thank you. So, one thing as a principle that we do, we never negate another vascular surgeon, but other specialties we do negate. You know what I'm talking about. So next, I'd like to call Dr. Love Luthra from Ludhiana, who has come all the way to spare his time with us. And he was to talk on the anti-thrombotic management, but that is known by everyone. He'll be talking about social media branding for vascular surgery. A very good evening to everyone. Thanks, Professor VSI, for this opportunity. You've been taught by the masters on management of DVT in whatever situation, special, unspecial, or very special situation. So I won't be talking about that. We need to change. Yes, Dr. Himanshu sir talked about AI in life. Abu sir has given, in 5 points, he's explained how we need to evolve, we need to change, we need to adapt. That is one thing that I think somewhere down the line we miss. Hey Meta, take a picture. I have those AI answers. I solved MCQ questions. Me and Ashu were just checking, and we solved those 20 MCQ questions in 2 minutes. There was one question where he gave us 3 options. Those were part of those options. And we just had ordered or just told Meta to go through the paper and tell us which kind of statistical analysis was used. And within 2 minutes, it went through the paper in IGPS and just gave us the right answer. One of my colleagues just said that, okay, patients are getting away. They see the complications, they see the treatments. Before AI, it was Google. Yes, let them see. When you are right, you are doing a right treatment, you are offering a right treatment to your patient, let them go through complications. It's good for us. See, technology has both advantages and disadvantages. It's up to us how we accept it. So I can take a picture of all of you. Hey Meta, take a picture. I'll click the picture. When I was about to judge one of the PPP sessions, just one of the topics, Abul sir told me, yaar, wo novel markers kaun se hain vascular. Just asked, and within seconds, those markers were there, where they are used, what is their sensitivity, what is their specificity. So we need to evolve. This is what the owner of Nokia said. We didn't do anything wrong, but somehow we lost. They were supposed to use. They didn't change. Being the masters of a mobile industry, they never thought that Android or Apple software can be in. They were producing different models, but the only thing, they never upgraded to what the world wanted. They failed. And see, where is Samsung, where is Apple? Change is inevitable. Growth is optional. It's always up to us whether we need to grow or not. To grow, you have to change. You have to adapt. We've evolved, isn't it? Today, if I'm standing, all of you are sitting, we've evolved. We've changed. And if we don't accept these changes and we just keep cribbing about all those things, iska ye nuksan hai, it has this disadvantage, we will never grow.
You have to be optimistic to survive in today's world. You cannot just let go things. We've evolved. As vascular surgeons, we were all general surgeons. In our training days, open Trendelenburg procedure was best, but we've evolved. We are in the world of glues, we are in the world of lasers, and we are able to give the best result because we've changed. All of us as vascular surgeons are confident enough to convince our patients that any procedure, minimal invasive procedure for varicose veins is better than Trendelenburg. How do we have edge over our competitors? There are general surgeons who are doing, there are plastic surgeons, there are cardiologists who are doing lasers. But the biggest advantage we have is that we are trained sonologists. We do our procedures under USD guidelines. That is the difference, that we are able to get better results than the other people. We cannot stop anyone to do anything. But yes, if we have changed, we have evolved, we have a better technique, we have a better device, our results will automatically improve. So, I gave this talk 2 years back in one of the midterms, in the midterm 2 years back. Probably at that time, in 2023, and we are in 2025, even when I was asked to make this talk by Kapil sir, I was just thinking, yeah, social media, kya baat karna, kya? But today, I think it's become part of our lives. It has become very important for all of us to tell people how we are treating patients, how we are giving them best of, operative techniques, and how are we different from others. Because if a patient walks in your OPD, he knows everything about it. I just asked Meta, who is Dr. Tapesh Sahu? And within seconds, it just replied. I asked, what is Vascular Society of India? Where is midterm being held? And it was talking to me. So I think social media is one of, I would say that it has become, one of the tools that we need to have in our practice. Especially in our, whether you're practicing alone, you are in a team, people should know how are we doing. That is why for the past 1 year, we've been, continuously telling all our colleagues, seniors, juniors, and everyone to engage themselves on VSI social platforms. The biggest difference between the Vascular Society of India and IR is that at least in the past 6 months, we are on social platforms and people have started to, they know about Shivanesan sir. We have a toll-free number. We have in VSI list, there's a list. Whosoever in any part of the country, if he wants to know about PC Gupta sir, Shivanesan sir, Dr. Ajay sir, Dr. Kapil sir, Dr. Rapoor sir, any vascular surgeon, they can just go in and search. So, social media is very important. We do not need to exaggerate what we are. At least we need to tell them what we are. And how are we different from others? How our techniques, like Sir said, in one of the points he mentioned in his experience of last 15 years, that we need to change. Newer things are coming up. Until and unless we do not try those things, our skills will not improve. Yes, there is always a commercial value to anything that comes in the market, whether it's, in any of the field, there is commercial advertisement, but the right advertisement is very well understood by the general public and the general population, and that is what is required. So basically, what are the key components of the social media? Website design, search engine optimization, pay-per-click, social media marketing, email marketing, display advertising, affiliate marketing, content marketing, and online reputation management. Basically, we all have our personal Insta, Facebook accounts, Similarly, we have those accounts for VSI, but we are more interested to see who see my profile picture. Okay, I posted, I'm in Goa, I'm having a beer with Dr. Tapesh sir. But no one is ready to see a midterm post that I posted that all of you brilliant students are working it so hard to win that trophy. So that is how we need to, improvise and improve. And as well as we need to encourage these things. Yes, you're doing laser, I'm doing this. But in my state, 50 people know that I'm doing laser because I'm promoting. If you follow all those Insta advertisements, and what I would suggest is that every single department of vascular surgery in India should have we have a VSI page. Even every single department should know. They should have a page and they should promote. Shiva sir, Rajesh sir, they're doing such brilliant aorta work. Everyone is doing a brilliant job, but everything is posted on VSI clinics. Instead, if every department has their own Insta and Facebook handle, probably the whole world will know. We share our VSI achievements and everything, and if we share it, everyone will know who is a vascular surgeon, what is a big difference between being a vascular surgeon and not being a vascular surgeon. Whosoever you are, if I am doing laser and you are doing laser, what is the difference? That is what we need to achieve. And somewhere down the line, we are still, lacking. Yes, we are using Chat GPT for making our presentations, for, just give a command to Chat GPT to convert this paper into PPT. But we are still somewhere lacking down the line. We are not understanding the power all these social media channels have. So even this slide shows that Indians are a bit slow to react in most of the things except a few. So scope in India, number of Facebook users by the country. We have the maximum number of Facebook. Probably we made 1 hour of our life, to give it to Facebook. But still, what are we using? How are we using it? We are not using it in the positive way, the way we need to use. Because until and unless people will know about you, know about your society, know about your work, we will never grow. So the strategies are very simple: to share educational content, the positive content you need to share, and your patient success stories, engaging with followers directly, dedicated business page, targeted advertisement campaigns, and even you can add your WhatsApp appointments. So I'll not be going in the detail of all the different that your social media handler will definitely explain you. So digital media is the need of the hour. Trust your skill and potential. Having true and unbiased feedback is important, because we heard that everyone is using, they pay that extra amount to give reviews. Trust your skills, be ethical, be honest, you'll achieve everything. Individual growth, institutional growth, group growth, and growth of society is again interdependent. Like I said, we all need to have our own pages. All the institutes, all the vascular departments in India should have their own page and share it with BSI. And time-bound analysis and improvements are definitely required to be successful in your life. Thank you so much.
Thank you, Love. You got a little emotional, but you should understand his point that he means that you should have more posts with regards to the work that you do. What's right, what's wrong, what's legal, what's illegal from the NMC and from the court point of view. We'll talk a little about that. But from the BSI, we do a positive branding. We want more inputs from you guys. We want more write-ups from you guys. We want more blogs so that we can make it more interactive. Right now, we have evolved in the past 2 to 3 years from where we were defunct. Now we have certain activities going on, and we talk about that on platform, but website still is lacking, and we should enhance that by your help. There are people who are doing that, but we have social media, Sil who is doing that, Love is part of that, Ashutosh is doing, everybody is doing, but you guys have to come up front and because feel as a vascular surgeon, part of the Vascular Society of India. Now, coming to the legal part, NMC has framed a rule that patient testimonials are not allowed. There is no thing that you can talk about as a personal name going forward. You can say if you have a change of place, otherwise putting it on hoarding is not allowed. What you can do, what you can't do on the social media. Dr. Ashutosh had a bad experience recently. I'll just talk about that. And then we'll go on to Love had showed a WhatsApp managing on the appointments that we'll talk to Dr. Ashish. First, Ashutosh, can you tell about you do a lot of branding online with regards to Lucknow practice? Can you just put a few words?
Practice, the first thing is visitors will make a website and you will see till 50% at least people are writing best vascular surgeon in that place. Any day Google will bank. You are not supposed to claim facts which are not verified. So when I write best vascular surgeon in Lucknow, this is not a verified fact. What I can write is MCH qualified vascular surgeon in Lucknow. Point number one. Don't make facts which are not valid. Number two, your website needs to have a privacy policy because you are talking about healthcare, people are seeking appointments. Point number three, your website should not have a pop-up which blocks entry into the website. Point number four regarding patient testimonials and advertising. So, if you are doing any soliciting means recently most of us do have, you will also have a team which handles. So my team tends to do vascular samasya ke liye turant mile doctor. This is fully illegal. You can't solicit patients at any cost. So if you go to my Facebook page or you go to Vascular Care, which is Tapisha's page, you go to PC Sir's page, it now never talks about it. It will tell about varicose veins, these are dangerous, and then the footer will have your details. But it should never mention meet Dr. Tapish Shahu for your vascular problem. And if it is mentioning, you have to remove it someday. So, unwary of these things, the posts were happening, and in January, my Google business page is blocked. The Google business page, once it gets blocked, you can Google it right now. There is a very rare possibility of getting it reinstated. You have to change the whole business. And they wrote only two lines, circumventing and cloaking. Circumventing is, you are writing best vascular surgeon. When the person clicks, it takes to Ashutosh Vascular. There is no mention of the credentials. Cloaking is like wearing a false cloak. So you are hiding facts. My account was banned for only 2 reasons, circumventing and cloaking. Then I visited my website. There was no privacy policy. What they did, and that will happen to most of you, they had put locations of all districts of UP. I mean, Ayodhya, Allahabad, everywhere. Why? For SEO. So, what is SEO? Love sir was telling about it. Search engine optimization. How it works. They put a lot of keywords. So those keywords will be like best vascular surgery in Jaunpur, best vascular surgery in Azamgarh, these are places in UP. So when I talk about other places like best vascular surgery in Delhi, Chandigarh, but if you are not having a proper address there, someday Google is going to recognize it and it will straightforward ban your Google landing page. And then believe me, I know at least 10 doctors who have got it completely banned. Now, okay, usually if you have a very valid reason.
So one thing suggestion about this, somebody might be like, I visit a couple of places. So if you are going into some other hospital also, Google will accept that. If
so I was coming to that.
You have to add on their hospital's website also.
I will complete that part in second thing. So how to act smart in these situations? Make sure your legible addresses are there. And that is how you can run ads. So it's quite similar for lawyers and doctors. We can't run ads for soliciting. So what kind of ads we run? I'll just tell the business transition. I was doing this OPD in my hometown Gorakhpur and I was not running ads. The usual OPD will be 10, 15, 20. So you are allowed to run ads for informing people about an OPD. Say if I go to Gorakhpur for second and fourth Saturday, that ad is allowed. And that ad can tell everything which I do. But it will not tell the best vascular surgeon. So if you go to my Facebook page, there is an ad always running. Varicose veins clinic in Lucknow, दूसरे शनिवार को निम्न समस्याओं के लिए मिले, and the date has to be mentioned because it's an announcement. and that is NMC guidelines revised in 2024. Announcement of practice can be made. Now this ad you can run, which will not be blocked by Facebook, and it works. When you go to the Facebook ad page, there are multiple options. Choose people with interest, choose people with location. So initially my team was running the ad. They were never adding the location. For a Gorakhpur OPD, they were putting locations near Lucknow. And I started making them, and slowly you recognize the patient base. They say somebody is working in Trivandrum. He has to put Kovalam, Varkala, the places which are around. Somebody working in Delhi puts Chandigarh, it's not going to work at all. There's no point of Chandigarh people seeing your ad. So there are so many things. So one is keeping things very clear, no soliciting. Don't declare yourself the best vascular surgeon. There's no certificate to that till now, unless VSI starts giving. And one more thing is about the testimonials. So a lot of hospitals and corporates will make testimonials. So I started this practice change up since 1 year. So I never sit with the patient and make testimonials. The patient speaks separately. In the video part, I will be just talking about the disease. So that's a change in practice. I am not talking to Shashikant ji ka humne introduction kiya. There I talk about acute ischemia. So that is allowed. You have educative content mixed with the patient content. NMC is very clear that you can't have a patient sitting with you and telling हमने इनका इलाज किया है, ये बढ़िया है और आप कैसा महसूस कर रहे हैं. This is purely banned, and now Google is linking. So I had a Google relationship manager. He exactly told me that these things we are banning completely. So one day or the other it will be caught. So just be careful. If you have a team, follow the local laws and ethics. There are ways to come out. You can always discuss with one of us. Almost most of us are running, sir also has the experience. So be careful.
So basically what he is trying to say is that whoever is running a field, most of us might have hired people. So it is your responsibility, not his, because it is you who is being advertised. So you have to take care of the content. You can't say that this guy was doing. Most of the people I have talked, well, this content was very good. He said, I'm not sure when was this posted because he's not doing it himself. So you are responsible for your page. Second is regarding reviews. Any review that comes, it's a double-edged sword. Positive, 5-star rating. Negative, 1-star rating. You are not available in your OPD or operating. You can put anything out there. So be careful regarding that also. Well, with regards to WhatsApp and with regards
I will add one point. So you will have reviews. Don't really be sad about negative reviews. They will bring you business. The moment you have 100 positive reviews, you will not be counted. So I was the 10th vascular surgeon in Lucknow. There were a lot of proctologists, radiologists. The moment somebody called me a murderer and killer, I became the second vascular surgeon. Because the Google software picks, now Ashutosh is legal, people are utilizing them. If you have 100 continuous 5-star reviews, there was a colleague radiologist. So he saw me doing this, he hired a company. And he got 1,000 reviews in 2 weeks. If you search, you won't find his name in the Google listing now. He has gone to the 16th position. So negative reviews, if genuine, they help. I mean, you should not have 100 negative reviews.
Doesn't mean you start generating negative reviews. But now with the cover now,
I mean, I was very sad for 2 days. Somebody wrote like this, but eventually you will get used to it and be ready for it. Negative reviews will come.
So I'll come to Dr. Ashish Sharon. He is to build up his practice in Jaipur and surrounding areas, being alien to the place, but then he graduated to becoming one of the successful people there. He does a lot of mobile-based things of OPD management. Any tips, any points you would like?
Good evening, everyone. So we had a lot of discussions about the technology, how to manage. I'm talking about the very humble beginning of like all the vascular surgeons, which most of you will have. So I started my practice in August 2020. I went to Jaipur. So like that was the time of peak COVID, and you cannot find any job. So like after being 17 years in medical college, MBBS, post graduation, senior residency, and then DNP peripheral vascular surgery, nobody is ready to pay you even 1 rupee. So how do you start your practice in that scenario becomes very important. So I made a list of hospitals. I visited them. I told them I do these surgeries, and they were like, our surgeons also do this. I do heavy fistula, I do varicose vein. So now it comes ego point that others are also doing. What should be my reply? So I started telling them, जब उनसे नहीं होगा तब मुझे बुला देना. So I never told them that give me a chance. I can also do, or I will do it at lesser price. So first pitch was like कि जब उनसे नहीं होगा तब मुझे बुला देना. So ठीक है, फिर calls आने लगे, and then started my practicing. slowly then धीरे धीरे problems आने लगती है कि how do you manage your phone calls, then you are doing outreach, how do you inform those people. So I created a system like I have a diversion system on my phone. So all everywhere my number is available. So it never this assistant's number is not available anywhere. And I gave them a phone. So all call will ring on my number and it will be diverted if I reject a call, if I do not answer, if I am not reachable, if my phone is switched off. In all those scenarios, the number gets diverted to the assistant phone. And there's a WhatsApp group in which 4 of my assistants are there. And whenever they receive a call, they have to immediately update me on that group. So I keep checking the group that any relevant thing, like some doctor has called or somebody wants to speak to me. So I have a very close tracking, minute-to-minute tracking of the things that if somebody wants to speak to me, I can call back directly and make myself available. And for all unnecessary things, I'm not available. Like a post-operative varicose vein patient is there, he's having burning, tingling. So one of my assistant is trained now for 2 years now. So I just direct Manish to talk. So he will, yes sir, spoken to him and then. So even without much investment or major things can be sorted. Then I'm going for outreach OPDs at 4 places. Now, how to inform all the time that I'm coming to their place and then any change in date. So like when I go to outreach OPD, I see 15 new patients. So all their phone numbers will be available on a group. There is a separate group of outreach OPDs and assistant will save those numbers on his or her phone and the email IDs will be linked, will be synced. So those numbers will be automatically saved on my phone. I'm not saving any phone number on my phone, but you have to sync the email ID. It means you have to kill your privacy at all the level. Like my email ID is saved in their phone and their email ID is saved in my phone. Or we make separate email ID, like multiple email IDs and then so all phones should be synced. So any person from your team saving a number on your phone should be available on your phone. Now, patients are calling on my number only. So when they have my number saved, I can use them for broadcast. So if I see 15 new patients on the way when I'm returning back to Jaipur, I save those numbers. I save in a pattern like my pattern is if I'm going to Ajmer, so I will save Ajmer, June 25 and the patient's name. So I know whom to include in the broadcast list next time. So those patients are added to my list next time. And whenever my next visit is there, I'll just put a message and it will be sent to all the patients. So these are the small modifications which I developed, which saves a lot of time and do a genuine, make you available also and still keep you free.
Any other points you want to put?
So you always have to devise your own ways. Like you should be empowering your team a lot, giving them free time, make make them earn well, make their source of income for them also. Otherwise, people will not stay with you.
Anyway, so this pattern might not work for people with girlfriends or extramarital affairs, but otherwise it works well. I've seen that. So, individual practice building, one tool that we wanted to give an example. This might not be applicable to people working in other sectors or people working in a team or, there's just an example of food for thought for everybody who might be able to utilize that. I just wanted to bring that point. Just one last point from Dr. Himanshu before we close up for the day.
So I would actually like to share one of my experience, and this is for who are maybe lucky or rather decide to go for a solo practice. Do not get intimidated by other specialty seniors who just try to show that you are not you are the newcomer. So I was called by one of the hospital where there was no previous vascular surgery. I'm telling about almost 7 years back. And they said, sir, you have to come for formality. There'll be some it was a multi-specialty hospital. There'll be some interview and there's some basic formality. And I just turned up in the morning. And to my surprise, the CT surgeon, senior one, is sitting in front of me, and he starts interviewing me. I felt a bit humiliated because I'm not there, literally going for an interview. I was told that I'm going here to do some paperwork. This guy starts asking me the steps of, how will you expose the aorta, how will you do it. So, well, I kept my calm and I actually answered him. And then he was done. Then he said, okay, well, let's something. By that time, I was decided in my mind, I'm not going to stay here. But then I said, okay, now you have done your bit. I need to ask you things. And I asked them, can you tell me branches of femoral artery and down, name by name, till femoral artery? Well, I said, well, you asked for your segment. There are other parts in body also that exist. Okay? So, anyways, and I then left. I said, if you don't know about this specialty, you have no rights. The point I wanted to come, when you go for, apply for jobs, there's a form called credentialing. Okay? And by default, sometimes if you do not have a vascular surgeon in that hospital, that credentialing form goes to the head of cardiology or to the CTDS. But you have right that, and you can ask the admin that because you do not have a vascular surgeon, that form can be actually sent to your parent organization. Typically, they just do it for if somebody is admin. That form can be sent to the institute where you're trained in, and they can do that credentialing.
Thank you, Dr. Machu. Thank you, panel, for enlightening us with this some facts before we close. So today the individual events have happened. We'll be putting the scores shortly on the group. Tomorrow morning we start with the team events for all, and that is the trophy that you can get your name on. In the last year, we have the names of all the institutes who have won this taken back to their home. We will have the case presentation, the quiz, the rapid fires tomorrow, and followed by the prize distribution. First, we'll start at 8:30 with some informal discussions as was happening now, but we'll have a bigger faculty tomorrow to talk to you. If you have any questions, you can ask tomorrow morning regarding this also. We'll be answering that. And then we'll try to finish off by 1:30. Any checkouts that have to be done, please make sure that you do that by 12 o'clock tomorrow, 11:30. And then from here only we'll get your transport arranged to go. Right now, BSI has 803 members, and we are adding around 80 to 100 per year that we are targeting. We are having a good visibility of the journal. We are having a impact factor of 0.2, which was 0, which was not included at a point in time on the clavicle analysis. We have applied for Scopus indexing. You might have seen on the group, and we have 2 journals running from the BSI. We are running our own LinkedIn, Instagram, all pages we are running. We need content from you guys. Feel proud to be vascular surgeons and part of the Vascular Society of India. We all are there to help you out. Thank you so much for being here today. Thank you. No dinner today. You are free to go out wherever.
इनोवेशन कर रहे हैं वहाँ पे पूरा इनोवेशन करके 10 मिनट में निकला मैं वही काफी कैंडल वही चलाऊंगा 20 मिनट में आधा घंटा
तुम लोग जाओ खाली इधर से तुम लोग
ये छोटू कैमरा बंद कर आप कैमरा पैक करो
हाँ कैमरा पैक स्टैंड खड़ा इसका क्या है स्टील का करना
ये यूट्यूब से बंद कर स्ट्रीमिंग स्टॉप कर स्टॉप ओबीएस में जा
हैं
ओबीएस में
हाँ है ओबीएस
ये लो इसका कनेक्टर जो है ना वहीं रखेंगे ये लेके आओ स्टॉप कर दो इसको लगा है ना नहीं लेके आ जोत भाई